Okay, Bernardo, we are ready to go.
Okay, welcome everybody. So nice to see you in the second day of this round of presentations of the MPH thesis program. This session is becoming like a classic of the program, and we really enjoyed. This year is especially challenging because of reasons that we all know, but it even highlights more the big effort of all the students. No, so for this session we have 13 presentations. Each presenter will have 10 minutes to present and 5 minutes for questions and answers. Nora will help us keeping track of the time. We will have a 25-minute break around 1:50. And in terms of the dynamic of the session, we would ask everybody to submit questions in the chat box or just raise your hands using the hand function of Zoom. So we can identify them, and Nora will help us also to identify and give the word for the different questions. We would ask everybody to keep yourself muted until questions and answer time so we can have a better listening. Videos may remain on and off depending on your preference. That's totally on. Just a comment, you may have seen the screen, but anyway, presentations are being recorded so we can share this with other people who are not able to attend. And well, if there is no other comment, Nura, any other thing to highlight? We really appreciate all the attendance of people who have helped the students, family, faculty, people in their thesis committees. And well, with no other words, I could give the word to Michael Light, who will start this session. So Nura, if there are no other comments on your end, should we move on to Michael?
Sounds good. Michael, is your committee here?
They are.
Okay, great. Go ahead and get started.
Okay, great. Thank you so much. It's a really a pleasure to be back in the Department of Global Health and see so many friendly and familiar faces. Thank you so much for having me here. So title change, but today we'll be talking about exploring the role of medical social work, findings from a pilot project in a national health center in Cambodia. Special thanks to my thesis committee, Tracy Hirachi, Dr. Jim Legerifo, and Lawrence Mars, a couple of whom could be here with us today. A little bit about myself, just appreciating positionality, that I do have a lot of identities of difference from a lot of the colleagues and the folks that I was working, the context that I was working in for this presentation. And I really appreciate the grace and support of my colleagues in Cambodia. Project role, I was responsible for most of the details of this entire project, so I can speak to them directly. I do also appreciate the leadership of PFH and my committee for supporting a lot of this work. And other roles, just to note that I did have a relationship to Partnering for Health, which you'll hear a little bit more about, helping complete a project needs assessment in 2012 for the pilot medical social work project, and provided ongoing technical support until earlier this year. So a little bit of background. There is very limited research on the practice of medical social work in resource-constrained countries, and identifying and explicating the role of social work has been thought to be really important for understanding how those roles and functions impact models of practice, clinical efficacy, training needs, professional development, and also the indigenization of practice, understanding what happens in a local context to think about what needs to happen in that local context in the future going forward. Specifically for Cambodia, social work is a relatively new profession, with the first graduates graduating from the Royal University of Phnom Penh in 2012. There is no government recognized job class for professional social work. That's how new it is. So Partnering for Health is a joint RUPP and UW venture focused on expanding social work practice opportunities, specifically in the healthcare setting, because that is where social work services have started in a lot of other countries. Needs assessment was completed at a national health center in 2012, and a pilot project was implemented in 2013 in a low-income medical surgical unit. So a little additional background, just briefly, this is a summary of medical social work roles and activities noted in selected literature from other low and middle income countries. You can see Cambodia there, 2017 really did qualify as a low middle income country. You see there's a little bit of a range. From this literature, you can extrapolate. A lot of these are not methodological papers. They're just kind of case reports of experience or historical reports of medical social work in these countries. But these are some of the social work roles and activities that were identified from some of that literature that did help think about some of the start codes for the data analysis. The real goal for this research was to examine perceptions of the role of social workers in a pilot medical social work project to better understand practice implementation and challenges and opportunities for the future. Methods, this was qualitative data collected from July to August of 2017, so it's been a minute. Human Subjects Division waived the need for full review, citing this as operational research. It was propulsive sampling with medical providers and social workers in the health center who had worked for at least 3 months and at least 50% of the time in this low-income unit with the social workers. There was recruitment support from the PFH staff. There were a total of 17 individually recorded interviews with a Khmer interpreter, along with the use of memoing, and questions focused really on the perception of social work roles, the referral process, and value and challenges of both social work interventions, working with social workers, and the pilot project. Analysis was use of open coding for preliminary theme development and observational data used to triangulate and understand the social work role and team interactions as well, and then data checking results with PFH leadership. General results, kind of on the high level, there was an understanding that there were role differences between providers and social workers. Obviously, providers thinking about the technical aspects of care, while social workers reasonably were focused on the psychosocial, socioeconomic concerns. Also really noted to have the time, skill, training, and other great qualities, inherent sort of like kindness qualities, to provide social, emotional, and problem-solving needs for patients. Also really understand that these were really complementary roles. So these were seen as working together as a multidisciplinary team to affect patient care, which is also really stunning considering that this has only been a pilot at this point, gathering the research of like 4 years, but really seemed integrated at the time. Some provider quotes here: to make good health, you must have good physical and psychological care. I think we have to work together so we can improve patient care and some problems that only social workers can solve. So there really was a reliance on this sort of team model of care, although it was still very much a forming and norming team dynamic. In terms of patients and referrals, the providers noted that social work was really indicated for these sort of categorical ideas of patients. So things, patients who were living in poverty, lacked family support, lost secure housing, had complex chronic health conditions or specific diagnoses such as HIV, cancer, or end-stage diseases, and had low medical literacy or barriers to navigating the system. It was also curious to learn that social work was seen by medical providers as not being indicated for folks who were just there for a medical or surgical complaint, that had family support, had their basic needs met, and didn't present additional challenges to the medical team. So the medical team felt like this is just medical care, that's all we need to focus on. So there was a sort of bifurcation based on these very broad categorical understandings of what patient needs might be. It's also important to note that referrals were seen by providers as necessary for engaging social work services. So providers really needed to identify the patients in order for social work to be involved. And those referrals were made on a case-by-case basis. We're not really a standard or systemic screening for those referrals. Prior to the project, in terms of providers understanding or learning about social work, most didn't really have a lot of experience. Some had some exposure to working with social workers and training, often outside of Cambodia. So say doing a medical residency in France. Some had exposure from social workers working for NGOs, either in outside organizations or coming to work within the healthcare center, but that was also very limited. Also, I think really important to note, there was no formal education for medical providers about social work or even psychosocial issues or psychosocial medicine. So really limited understanding also of the program and the pilot. During the pilot, they really noted that one of the ways they learned about social work interventions was through this iterative process of direct contact. So during referrals, witnessing interactions with patients, discussing with colleagues, and requesting information directly about social workers in their role. So it was kind of this ongoing sort of iterative learning process for kind of like seeing and working with them together to understand what they did. It's also, I think, important to note that there's no shared medical record. So notes between providers, there's limited communication that's shared in a sort of formal structural way. And that some providers did really note a desire for information presented about or presentations about social work too. One provider quote, "If because my colleagues, they never worked with social work before, they think the social work is not useful, but when they work together, they think social work has a role." So just highlighting that, that focus on understanding social work through direct practice. In looking through the interview data and doing some of that open coding, what I really identified with, there were a number of categories of social work roles and sub-themes. What's curious about this, if you see these gray lines, these are sort of the primary social work roles that most of these 6 categories were identified by both providers and social workers. So the information gathering, patient education, emotional support, discharge planning, referral linkages, and material resources. What's also curious is that these white lines, there are these sub-roles. Does the detail, the depth and breadth of that work was better described by social workers, more complexly described with additional sub-roles by social workers, as well as social workers uniquely identify an additional role of opportunities in addressing behavioral health issues. So providers did not identify social workers as being important in having a role with behavioral health. And while it's sort of a new and burgeoning role, social workers felt like they needed more skill around it. Social workers did identify things like crisis intervention, suicide assessment, mood disorders, and referral for outside treatment. Those were things that they exclusively described.
2 minutes.
So a couple examples, I think I will focus, there's some difference in showing some of the data of what both groups identified and what social workers described uniquely. I'll focus a little bit here just for time on behavioral health. Again, there was no mention of mental illness, suicide risk, or substance use in the provider group. Furthermore, they noted that that was really not their job. There's another hospital for psychiatric patients. For psychotic patients, we're not the psychiatric doctors. So there's a limited understanding or sort of appreciation of behavioral health issues in the country or within this team as well. Social workers, on the other hand, noted that this was an important area of practice they sought within their scope. But in bold here, we see that they also noted limits in their training, knowledge, and skill, particularly with complex psychiatric diagnoses. So recommendations, there were three sort of like key areas in the discussion recommendations. One, I'd appreciate that there's a shared perception of the social work role between groups, but there's a gap in both the depth and breadth of that understanding of a social work role or what the capacity could be, especially regarding mental health. And those really likely impact the access to care that patients have with that referent power that, that providers have in needing to mediate the access to social work services. That a shared understanding of impacted education gap and limits create an opportunity. So a real recommendation for taking this sort of like informal learning about what social workers do into more formal spaces, providing presentations, direct lectures, referral pamphlets or materials, things that can really help increase that communication understanding across teams. And also thinking about other models of care that can help overlay a lot of the issues that were being faced in sort of role definition. So one of the big ones is thinking about the WHO recommended evidence-based models for team-based care, because they're really working a team, they see themselves as a team. There's a lot of focus in this model of care on interdisciplinary role definition and collaborative training, and also a real focus on communication. Processes and tools, for example, consults, the use of SBAR and other tools, and shared documentation. So finding a way that not only do they share learning together about what their roles are, and then create communication tools and forums that allow them to build that relationship together for better shared patient care and better understanding of those shared roles. Just some limitations to note here, and a little bit of a postscript. The social worker, one of the social workers hired into the hospital, not as a social worker, because there's not a social government role for a social worker, so they're hired on as a technician. This pilot has sort of changed iterations in various ways. One key note, I think, from a provider here, we're always thinking about the future, but if 1 year or next, the social worker, they stop working here, I can't discuss about the future. There was a real awareness that the soft funding that often comes from organizations in Cambodia really limits people's ability to trust that certain services will be available in the future. Just a quick set of acknowledgements to some of my colleagues, especially to Dr. Tracy Hirachi, my thesis chair, longtime friend and mentor who helped start the RUP social work department in Cambodia and was also co-founder of PFH, who is really the spearhead for a lot of this work. So thank you. Happy to take some questions.
Thanks so much, Michael. Nura, you want to coordinate the questions, comments?
Yes, there aren't any questions yet. I see one from you, Bernardo, but I'm going to wait to see if anyone else has questions. All right. Well, Bernardo, please.
Okay, no, Michael, thanks so much. Very interesting work. Something that calls my attention is like, oh, you have the community, the population you have the technical providers, let's call them like that, and you have the social workers, people who are more in the community. Did you find, or you think some factors like the personal history of the people working on social work and their background and links with their community can affect their role? Who is like the best profile to also work as a liaison with the communities?
Yeah, so if I'm understanding your question, like how sort of like personal histories of the key informants may have affected like their perspective on
exactly
the role in the community. Yeah, that seems that's a very interesting question. I mean, one of the things that I feel I'm very aware of is that just it being such a resource constrained country, there are dynamics like the physicians are often, most of the physicians are only working for the morning before they leave for another job that like might pay them more, pay them additionally in the evening. Social workers were very aware of the limited access. So there's a lot of folks trying to figure out how they not only take care of patients in these complex systems with limited resources, but also how they care for themselves. So I just think that enters into care a lot when you're thinking about what are the resources people have personally and within a system to think about how they're meeting these really complex needs, and understand and appreciate there aren't a lot of community-based resources that I, as a social worker in the United States, may have access to in the Seattle area. There just aren't a lot of places to refer folks to. So yeah, I think that can lead to a lot of like moral distress and also a lot of limited understanding about complex psychosocial issues when there's not maybe so much you feel like you can do to intervene with them. I don't know if that directly answers your question, but.
No. Thanks, Michael.
And Michael, we have a question from Deepa and also plussed by Leslie, who says, great work. I wonder if you can speak to whether or not you identified any culturally specific adaptations to the social work role in your work.
I think one of the biggest things that sort of got talked about is thinking about the family dynamics. In the United States, we talk a lot about folks who are homeless. In Cambodia, we talk about folks even who are living outside or living on the streets, that's sort of unaccompanied. Those are folks that don't have family to care for them. So that real switch, that transition, that it's not necessarily like about housing structure or the socioeconomics, it's also about the fact that there's not family support of someone that's able to care for you, whether that's due to disease and disability, a long history of genocide and loss of family, substance use and mental illness. And that actually creates a big bifurcation on what access to resources you have, because families are also often responsible for providing care in the hospital. So I think making those adaptations and thinking about really how does the family context provide a lot of the support and resources, and how is family even drawn in when families maybe been disengaged for a while, but that focus on family context and a lot of communication skills around really what role family is going to have in care outside of the hospital, maybe even differently and more broadly than is maybe as common in the United States.
Great, thank you so much, Michael. We're at time, thank you.
It goes quick, huh?
Yeah, it does, thank you.
I just want to say again, it's such a pleasure to see you all. Thank you also for supporting this very long journey for me. I have a lot of love for you. Thank you.
Thanks so much, Michael. Great work. And with this, we would move to the next presentation, which is by Emma Rogowski from the Health Metrics and Evaluation track. Emma, please.
Thanks, Bernardo. Hi, everyone. Thanks for joining today. For my thesis, I've been looking at mortality due to war and terrorism as a predictor of measles incidence. And this work has been supervised by John Moser and Moy Q. First, I want to recognize that my positionality, particularly that I've never lived in any of the countries that I'm studying, and I don't have any firsthand experience with the trauma and loss of life and health that goes with living through armed conflict. With this project, my involvement has been in conceptualizing the project, analyzing the data and interpreting the results, but I didn't do any primary data collection. Armed conflict disrupts a number of systems in countries that can increase the incidence of infectious diseases. Decreased funding and supply chain disruptions can mean that the supplies and human resources aren't on hand to administer vaccines, which lowers vaccine coverage. But beyond coverage, there can be increases in malnutrition, which lower immunity, and decreased funding for the health system means that it's harder to track and respond early to outbreaks. This association has been looked at for some infectious diseases, polio most extensively, and for polio, conflict has been identified as a contributing factor in the reemergence of and delays in eradication of the disease. But more generally, periods of conflict are often tied to high levels of vaccine-preventable diseases. And 2 examples of this are during US troop surges in Iraq and during the ongoing war in Yemen, in the case of diphtheria. There have been single countries that have, I'm interested in measles specifically for a few reasons. The first is that because measles is so contagious, you need really high proportions of the population to be immune to get to herd immunity. And so the war-induced decreases in vaccine coverage could quickly spark increases in measles incidence. Also, elimination of measles has been set as a goal by WHO, and it's important to understand what's contributing to its spread today in order to achieve that goal. Also, in some countries like Syria and Somalia, there have been reported increases in cases during or soon after periods of conflict. But as far as I know, there isn't any work that quantifies this association between measles incidence and conflict across space and time. So this project is filling that gap. My project had 3 main aims. The first was that before I could dive into looking at disease incidence, I looked at if there was evidence for changes to surveillance system quality associated with conflict. It might be that a higher proportion of cases are not reported during war years than are not reported during non-war years, and this would be important to consider because I'm using reported cases as my outcome of interest. As my second aim, I wanted to quantify the drop in vaccine coverage that was associated with war and terrorism across all countries in my model and time. And then I leveraged the output of the second aim to produce my end goal, which was a set of conflict-inclusive estimates of measles incidence and a set of conflict-free counterfactual estimates of incidence. And I look at the relationship between those 2 sets of estimates to understand how war and terrorism mortality rate is associated with incidence. I did this for 106 high policy priority countries from 2000 to 2019. To address these aims, I used a number of data sources. For the first aim, I used data on measles testing from WHO. For the second aim, I used IHME's estimates of first and second dose measles vaccine coverage and IHME's war and terrorism mortality estimates. And then for the incidence analysis, along with the results from the second aim, I used WHO's measles incidence time series, as well as, again, IHME's war and terrorism mortality rate estimates. In a disease surveillance system that's working well, you expect there to be some negative tests. And for measles, WHO has set a goal that this should be at least 2 negative tests per 100,000 population. So I examined how well war and terrorism mortality rate predicts if a country meets this WHO standard. And on this slide, you see an ROC curve for that relationship. Anything that falls on the dashed vertical line in the angled line in the background indicates that the predictor is doing no better than a random guess. And so since the solid line is pretty much on top of that line for the whole range of values, this indicates that for the years I have testing data for, war and terrorism mortality rate does no better than a random guess at predicting if a country year's surveillance system meets the WHO standard. I want to note here that the data I have on testing are very noisy and variably reported, and some countries stop reporting these testing data during conflict years. So this is an association that should definitely be looked at further, especially because there's reports from single countries that there are significant breakdowns in systematic surveillance, particularly early during conflict periods. But for the purposes of my project, I don't have evidence of war-associated changes to measles surveillance system quality. Moving on to the second aim, to be considered fully vaccinated for measles, you need to receive 2 doses of the vaccine. And on these plots, the first dose is shown in red, the second dose is shown in blue, and the solid lines are the original IHME estimates that include conflict. The dashed lines are the conflict-free adjusted estimates. And the difference between the dashed and solid lines is the drop in coverage associated with war and terrorism mortality. Yemen and Iraq are shown here just as 2 examples. I produced the conflict-free estimates in the dashed lines from IHME's models of vaccine coverage. These models combine several distinct models to create estimates of coverage that include doses that are administered through routine immunization, as well as doses that are administered through campaigns. The model for the routine immunization portion includes war and terrorism mortality rate as a predictor. So from that, I could estimate what routine immunization coverage would have been had there been no war and terrorism mortality in the country year. Since campaigns follow a much less consistent schedule, coverage achieved through campaigns wasn't adjusted. And then I leveraged those estimates of counterfactual coverage in the drops to help generate estimates of incidence. I fit a mixed effects model to the log transformed measles incidence rate. And in this model, I found that higher rates of war and terrorism mortality and larger drops in coverage were associated with higher measles incidence rate. To get my conflict-free counterfactual set of estimates, I set the green covariates here and the red war and terrorism covariate to 0 when predicting out. And then to adjust for underreporting in countries that don't have verified strong surveillance systems, I used a standard random effect when predicting out. I also wanted to understand the uncertainty in these estimates, and to get at that, I used a variance covariance approach. On this slide, using Afghanistan as an example, you can see how the counterfactual coverage estimates and drops in coverage translated to conflict-inclusive and conflict-free estimates of incidence in the figure on the right, where the conflict-free estimates are in blue and the conflict-inclusive estimates are in red. On these maps, the countries in gray are ones that were not included in my model. And in the colored countries, the color indicates the percent by which the conflict-free incidence rate is lower than the conflict-inclusive incidence rate. This map is for 2000, and then this map is for 2019. So in 2019, there are more countries that are in the blue and green side of the color scale, so smaller percent difference, but there are also now countries and more countries that are bright orange or even red. So the percent of incident cases associated with war and terrorism has increased in some countries from 2000 on the last map to 2019 on this map. And the kind of take-home finding here is that we can't expect to achieve measles elimination without addressing the effects of war and terrorism. Through this work, I found that conflict is associated with the continued spread of measles, and part of this is definitely through vaccine coverage, but focusing only on maintaining vaccine coverage isn't sufficient because even in my model where I control for coverage, the war and terrorism mortality rate is still positively associated with incidence. Also, like for polio, as has been observed in single country case studies for measles, we find that across countries in time, armed conflict events have been associated with drops in coverage. These drops tend to be larger for the second dose of the vaccine than for the first dose of the vaccine. There should definitely be future work to investigate measles surveillance system quality. The current data gaps make this challenging, but it should be revisited. And also this should be examined at the subnational level because conflict events are often concentrated in one region of a country, for example, northern Nigeria, and looking at the national level is likely masking important subnational variation. This work is subject to a few limitations. One of those is that the counterfactual conflict-free estimates assume time and location invariant effects of war and terrorism. Additionally, right now I can't fully account for underreporting or war-associated changes to surveillance system quality. And I also can't account for multinational effects of conflict in a single country. And what I mean by this is that refugees might move to a different country, like between Somalia and Ethiopia, and the outbreak might wind up happening in the relatively more peaceful country in the refugee population, rather than the country where the war and terrorism mortality rate is actually higher. I'd like to thank a number of people for their help with this work. My thesis committee provided endless support. The vaccines team gave me help that was essential to coming up with these coverage estimates, and the WHO VPD data team gave me the testing data that let me get at my first aim. I also want to thank Amy Hagopian and the fellow students in my thesis class this fall that helped me gain insights and connections as I came up with this project idea. And I also want to acknowledge all those who are living in and providing care in conflict settings and gathering data during times of conflict. Thank you.
Thanks so much, Emma. Great work. Really, congratulations. We would have some minutes for comments and questions. Please, everybody, feel free to raise your hand or use the chat.
Could ask a question. It's my go-to, but I know 10 minutes is a short time and this is such a robust body of work. Was there anything that you found interesting or enjoyed learning about that you didn't have time to share that you'd want to share now?
Sure, I guess there's definitely a lot, but the first thing that comes to mind is that I guess it kind of showed up on the maps, but if you actually look across all the countries, the change between conflict-free, or the difference between the conflict-free estimates and the conflict-inclusive estimates, isn't that big. So because countries that have a lot of cases like India don't have that much conflict, but it's very important for individual countries. So this is something that if you are looking in aggregate, you won't see as much, but in order to achieve that goal of elimination, it's going to be important and to direct resources appropriately.
Nice. Emma, you have a question from Steve who says, nice presentation and project. Did you have any data on percentages of reported measles cases that were vaccinated / not vaccinated?
No, the data that I got didn't include that. I'm sure that exists for some instances, but it's not reported as far as I know in the joint reporting form, which is how WHO gathers data on cases each year from countries' ministries of health. And then the testing data that I got, just the number of positive tests and the number of tests administered, nothing about vaccination status.
Great, thank you. Bernardo, please.
Oh, no, Emma, congratulations. I mean, this is really interesting. And looking at the graphs that you show presenting like this gap between the conflict adjusted and non-adjusted coverages, it calls my attention. I mean, in both lines, you see like these hips over time. Is it possible like conflict has some sort of like a spillover effect or a delay effect that may be affecting like everything? It may be related to the last limitation you mentioned.
Yeah, I think one way to get at that would be including kind of lags where you look at the war, terrorism, and mortality rate in the previous year or several previous years if you're talking about spillover over time. I looked at that in the incidence model and it didn't improve the model fit statistics, but that would be something good to look at for vaccine coverage as well in the future.
Great. Any last minute questions for Emma? Okay, well, if anything comes up, please make sure to add it in the chat box and Emma will reply to it in public. So thank you very much, Emma.
Thanks, Emma. We will move then to the next presentation, which is by Chelsea Elkins. Chelsea, please go ahead.
Hey, thanks, Bernardo. Just share my screen. Oops, skipped ahead. Spoiler alert. Okay, can you all see that?
Yes.
Okay. And before I started, I did just want to acknowledge that today is a really heavy day for multiple reasons. So thank you all for being here, and please take care of yourselves and each other. Okay, so my name is Chelsea Elkins. I use she, her pronouns, and today I'm going to be talking about my thesis titled Endless Opportunities, a Qualitative Study on Improving Two-Way Texting for Voluntary Medical Male Circumcision Follow-Up in Zimbabwe. I have to give so much thanks to my thesis committee, including Dr. Carol Feldacker, Dr. Kate West, and Doctor of Global Health candidate Fiona Marongwe. Okay, so a bit of background. In Zimbabwe, the HIV prevalence is about 14.6%. Voluntary medical male circumcision, or Bmmc, can reduce HIV transmission by up to 60% in males. Like in many places, there are healthcare worker shortages in Zimbabwe, but two-way texting, or 2WT, has been shown to increase healthcare worker capacity and also decrease burden on health systems and clients. So about this particular two-way texting system for VMMC, it consists of 14 daily post-operative text messages where clients can respond with either a 0 or a 1 based on if they are having any signs of adverse events or if they have concerns that they want to talk to a healthcare worker about. And how did we get here? This specific system was scaled up from a randomized controlled trial to the routine care context, in large part led by the partnering organizations you see on screen. Notably, this as a consortium, which consists of local Zimbabwe organizations, including Zimtech, Zachiri, and Zach, as well as Medic, which was the technology partner for this project. You probably know Zimtech is a network partner of ITech, which is a center that is based within DGH. So not only are these organizations, particularly the top 4, doing this work, day in and day out, but they were also the sample of this qualitative study. So this work couldn't have happened on any level without them. There were a lot of successes in the transition to scale up, but also some road bumps and challenges along the way. And that leads us to my research question, which is, what do program partners identify as the barriers and facilitators to two-way texting scale-up in routine practice? As I mentioned, this was a qualitative study, and it was really centered in a pragmatic paradigm. My sample was 16 program partners across the organizations that I had shown before. The majority were from Zimtech, 3 were from others as a consortium members, 5 from Medic, the technology partner, as well as 2 Ministry of Health and Child Care site nurses. We recruited these program partners using a combination of purposive and snowball sampling. And I'll say that I interviewed 15 of these program partners on Zoom, while my colleague Fiona interviewed 1 person via WhatsApp due to connectivity issues. In terms of our data analysis, I used a combination of inductive and deductive methods. Our deductive methods was rooted in the two-way texting theory of behavior change, as well as in our interview guide, which was created with the PI, key contributor, and myself. We also did open source coding to make sure anything that was unexpected was captured and coded and identified themes from. I coded using Atlas TI, and I gave a glimpse of my codebook development. This is going to continue to shift as hopefully a second coder is going to go through all these transcripts in the next 3 months. So I'm looking forward to seeing how this continues to evolve. So the findings, what did we find? I identified 4 main themes that related to my research question, and I mapped those themes to some of the most commonly brought up facilitators and barriers program partners identified as impacting texting scale up in the routine care context. So the first theme was community buy-in. Community buy-in, in part due to demand creation led by healthcare workers, has supported two-way texting program acceptance and success. As the theme, and you can see a facilitator and barrier I listed that program partners identified. The second theme is training. Two-way texting training is comprehensive and positively received, but cascading training could improve sustainability and scale-up efforts. One of the barriers that a lot of partners mentioned was that not enough two-way texting trained staff were at all of the sites, whether that's due to turnover, even people going on holiday, or just from sometimes disinterest or lack of engagement from healthcare workers in the two-way texting system.
5 minutes.
The third theme spans these last 2 rows, and that's that two-way texting technology can impact successful engagement on both the system and user level. So an example of a system technology barrier might be poor mobile network or poor cellular service, whereas the facilitator aiding success on the user side is that both clients and healthcare workers really find the two-way texting app easy to use. So I wish I could just spend this whole 10 minutes going through, illustrative quotes from the partners. They said all of this better than I did, but I want to highlight one system barrier, which I coded as system enrollment limitations. So a partner says, some clients may be coming from the same family. They have 1 phone and the system doesn't take more than 1 client with the same phone number. That has limited the recruitment as well. So even though most people in Zimbabwe and in the world do have access to a phone, not everyone owns their own phone. So if 2 people are coming from the same household and they share a phone, which can be common, only one of those people can be enrolled in two-way texting with that number. So this study was just happening at a really interesting time in the project, as while these interviews were taking place, actually, two-way texting started to allow minors aged, I think, 15 to 17 to be enrolled in the program. And as we know, the younger you are, the less likely you are to own your own phone. So talking to Medic and some of the technology partners who participated, it does sound like some technology enhancements are occurring to address this and some other things, but during the interviews just hadn't quite trickled down to some more way. It's really interesting to see how that progresses. My final theme wasn't around the facilitators and barriers, but rather it was kind of this collective visioning that partners had on, what they see as the future of two-way texting, beyond this system. And, two-way texting is used already in different settings and conditions, but there was just a lot of optimism and excitement from, as a consensus from program partners about ways they think this can be utilized. So non-communicable disease care management was mentioned, ART adherence, maternal and child health, vaccine follow-up, as well as this partner says, two-way texting has come at the right time because we are able to review clients without physical reviews. We are reducing the contact between the health worker and the clients themselves. It's helping us during this COVID outbreak. So this is actually something that came up a lot, this idea that this can also help with COVID prevention and control.
2 minutes.
So in conclusion, there was, a lot in this, my preliminary findings, and a lot of ideas and takeaways. And, one is just cascading two-way texting training to just try to alleviate some of the gaps in two-way texting trained staff that was identified, as well as continue to monitor some of these program changes, including the inclusion of minors. Several technology enhancements seems like they were in the works. And of course, my primary next step is to disseminate this information to all the program partners. And hopefully this will be a practical foundation that might inform future quality improvement and scale up. So I actually wanted to end with my positionality instead of begin, so you had a really clear idea of what the project was and what aspects of my positionality might impact my interpretation and work. First is that although I'm not an employee at iTech or SimTech or any partner organization, I'm very much affiliated with DGH, of course, which again is a center that iTech lives within. I'm American, I'm raised here, and while I have done work in Southern Africa, I've never done any work in Zimbabwe, and I've never even been there. I'm also multiracial, but my lived experience has been as a white, queer, cis woman, and all of these things, of course, impact how I interact with the world and this work. So last thank yous, each program partner who shared their experience, again, my wonderful thesis committee, and my many support systems, many of whom are on this call today. As one program partner said, we have a lot to really celebrate. Thank you. Take questions now.
Thanks so much, Chelsea. Great work. We have some minutes for comments, questions. Please feel free to jump in.
All right, Chelsea, that was amazing. Some congratulations for coming in. And we have a question from one of your peers, Emma Murphy, who says, amazing presentation. Is there a reason clients were not included in the study? Are there plans to conduct further research to discuss these topics with clients?
Amazing question, Emma. Thanks for keeping it definitely equity centered. So in this whole rollout of the randomized control trial, clients were of course really involved. There was qualitative research done at that time, and there's also a two-way texting program in South Africa where further qualitative work with clients is being done. And even the design of the two-way texting system itself was a human-centered design, so built with and for clients. So we actually felt that we had that information from clients, but what we were kind of missing were this other side of the implementation was the actual implementers who had a lot of valuable insight as well, and maybe were more in the background, but still an important part of scale up. So that is kind of what we were trying to fill that gap.
Thank you. I have a question from Fatima. Fatima, go ahead, please.
Thank you, Chelsea. That was a really nice presentation. My question for you is around people who are illiterate. Is that something that you discussed with your program partners?
Great question, Fatima. Thank you. Yes, so client literacy is a really great question. Again, another equity-centered one is something that came up. And partners were like a little bit divided where, as I showed you that screenshot, when clients respond, they can use a 0 or 1. And that kind of idea is that even a client who isn't literate could still participate. Though, it did get mentioned a lot where, I remember one partner said, two-way texting could not be simpler to use if you can read or write. So I do think there are maybe still some barriers. And even a lot of people said that even clients who were literate, instead of texting a 0, sometimes they would text an O, like the letter, which is just obviously something that can come up for anyone. So actually a handful of partners kind of had this idea of incorporating a toll-free line to kind of increase that. And yes, Carol, thank you. And literacy is pretty high in Zimbabwe, but that definitely was on people's minds. So thanks for that question.
Thank you. Joe, I see your hand, but I'm going to prioritize the student and then I'll get to you. Sammy, go ahead, please.
Hi, Chelsea. As you know, you're my favorite presenter. Your voice is so romantic when you speak. My question for you is, were there any other findings that you wanted to share that was not, that you couldn't because our presentation time is so short?
Yes, great question. That's my favorite question. I think I'll share screen again. Yeah, I think one thing that kind of stood out to me was kind of here in the user barriers, something that came up a lot. And again, these are from program partners. So this is, perceived kind of client barriers, but this idea that there maybe was too many messages, where that 14 messages, it's the same thing every day. People were saying some clients were complaining that it maybe is, a little tedious or boring, especially if you don't have good cell network. Maybe you have to walk around to get service. So a common thing that came up was multiple partners suggested reducing the number of messages or even doing it on key days, such as day 2 and day 7. So that was something that came up a lot and I thought was interesting. And yeah, I don't know how feasible that is, but could be interesting to see. Sure. Thank you, Sammy. Thank you for your voice compliments.
Great. So we're at time, but Joe, if you can please put your question in the chat box, that'd be great. And Chelsea, there's a question from Deepa also in the chat box, if you can address that as well. Good job.
Thank you.
Thanks so much, Chelsea. Fantastic work. We would move to the next presentation that is by Adriana Velasco. Adriana is a student in the Masters of Arts in Applied International Studies, doing also the graduate certificate in global health. So happy to have you with us, Adriana. Please welcome and go ahead.
Yeah, hello, nice to be here. I'm gonna start sharing screen. There, do you see it well? Yeah.
Perfect, thank you.
Thank you. So yes, as Bernardo was saying, my name is Adriana Velasco. This is my presentation for my capstone project for my certificate in global health. And I will also be graduating with a master's in applied international studies from the Jackson School. And today I will talk about climate justice in Latin America as a response to the rise in heat waves. So what you see in the screen are headlines and pictures of a heat wave that affected Argentina and other countries in South America in January this year. And even though it was summer, there were more than 2 weeks of very high temperatures. In some cities, they were 25 degrees above normal. And these heat waves, that the one we see in that was experienced in South America, are part of effects of global warming and are being experienced more often across the globe. The main ideas of my presentation are that first, depending on personal and community characteristics, some populations are more vulnerable to heat waves than others. Second, in terms of equity, people shouldn't face different health risks according to their personal conditions. Specifically in Latin America, certain circumstances put some population at higher morbidity and mortality during heat waves. And finally, that mitigation and adaptation measures must consider targeted policies to reduce the vulnerability of the groups most impacted by the hazards of climate change. A little bit about me, I was born and raised in Argentina. I also lived and worked in Dominican Republic for 5 years. For about 20 years, I have worked as policy analyst on international development for the United Nations for several countries in Latin America. And you can see at the bottom, there is a picture of Mr. Kofi Annan when he visited the Dominican Republic office, and I'm there in white. We will go through some definitions first. A heat wave is a period when daily mean temperatures remain higher than certain threshold for at least 2 days. During the last 85 years, heat waves have affected more than 100 million people and caused about 184,000 deaths worldwide. And research points out that climate change will increase the frequency and intensity of heat waves in the future. So we need a normative framework to guide our policies and actions toward climate justice. In this case, I base my analysis on the concept of equity and justice from the capability approach. So in terms of equity, every person must enjoy the same range of capabilities in life. These capabilities include living a long and healthy life, being educated, having adequate nutrition, etc. In the case of climate change, more specifically, during a heat wave, if some people are impacted differently than others, that is, if their capabilities are reduced compared to others, that situation is considered unjust and unequal. And then climate justice advocates to achieving equity and justice when addressing climate change. Climate justice rests on 3 principles, but in terms of time, we are going only to focus on one, that is the distributive justice among people of the current generation, the people that are living today. That is justice between men, women, youth, elder people with different ethnicities, socioeconomic status, etc. Other important concepts are risk and vulnerability. Due to climate change, people and nature face risks. For people, it means increased morbidity and mortality. For nature, loss of biodiversity and degradation of ecosystems. As we can see from the diagram, the risks that emerge from climate change appear from the intersection between the hazards, in this case the heat waves, the exposure to that hazard, and the vulnerability. People's vulnerability to heat waves varies according to both personal and community factors, as we can see on the diagram. In red, we find the individual factors, for example, income, age, sex, type of housing, health status, etc. In yellow, we find the community factors, health systems capacities, the urban designs, social networks, warning systems, etc. Early populations and young children experience increased health risks, especially in urban settings. For adults, the main health complications include cardiac arrest, heat stroke, and respiratory diseases. For children, electrolyte imbalances, fever, renal and respiratory diseases, lethargy, headaches, and rashes. Heat stress and dehydration also translate into behavioral and learning issues, increased anxiety, depression, and some jobs like agriculture and construction demand workers to be more exposed to heat than others. All of these conditions determine people's vulnerability to heat. So moving on to Latin America. In first place, Latin America is the most unequal region of the world in terms of income distribution, as we can see at the graphic at the top. Poverty is also a problem. 1 in 3 people in the region live in poverty, and 1 in 7 live in extreme poverty. But as shown in the graphic at the bottom, some groups experience more poverty than others, such as women, people living in rural areas, children under 14 years old, Afro-descendants, indigenous population, those with the lowest education.
5 minutes.
Other vulnerabilities for poor people include living in overcrowded houses and lacking access to essential services and social protection. In Latin America, healthcare systems also reflect inequalities. On average, health systems are fragmented, unequal, underfunded, and deficient infrastructure and lack of human and technological resources. Usually, the quality of healthcare services depends strongly on the patient's income level, if they can access sometimes private clinics or travel outside the country. Another characteristic is that Latin America is the most urbanized developing region in the world. More than 80% of the population live in urban areas and 35% live in cities with over 1 million people. Some cities have urbanization that has been rapid and unplanned with poor utilities, few parks, green spaces. To conclude, some people in Latin America face compounded vulnerabilities that expose them to greater health risks. Heat waves in Latin America. A simulation with data from 1960 showed that climate change is increasing the frequency and intensity of heat waves. In recent decades, the percentage of extremely warm days during the summer months, that is between December and February, more than doubled in North and South America. By the year 2050, under an intermediate adaptation scenario, RCP 4.5, heat waves are expected to be more frequent and last longer. For example, in Southern South America, heat waves are expected to at least double. But near the equator and in the Atacama Desert in Chile, heat waves are expected to increase by 5 to 10 times. Under a worst case adaptation scenario, RCP 8.5, the projections are of course more striking, especially in the tropics. These projections should be used to prioritize adaptation strategies in areas where heat waves will be more pronounced. So has mortality been affected by this extreme heat? Studies show that excess death fraction of total deaths from heat was 0.67%. These excess deaths were especially higher for people aged 65 years or more. Also, a 1 degree increase in daily temperature was associated with a 5.7% higher all-cause mortality in extremely warm days, implying that the marginal increase of only 1 centigrade during hot temperatures has a substantial impact on mortalities. We can see in the graphic where are the cities most impacted by this marginal increase in 1 centigrade. Southern Brazil, Argentina, and parts of Mexico.
2 minutes.
In this presentation, I describe the differential risks and vulnerabilities to heat waves experienced by people in Latin America, especially in relation to income poverty, inequalities, and urbanization. These vulnerabilities and risks vary significantly within the region and within countries. So, what are some pathways to reduce morbidity and mortality during heat waves? Some priority mitigation efforts must include curbing deforestation and degradation of forests, reducing vehicle emissions, promoting energy efficiency, renewable energies. In terms of adaptation, national and local actors should promote and expand green spaces and water security in urban settings, curb air pollution, develop targeted early warning systems, increase public health education, and strengthen health systems. Incorporating indigenous and local knowledge can enrich these adaptation efforts as well. In conclusion, policymakers should implement national and target policies to decrease the vulnerabilities of the people most affected by heat waves and other hazards related to climate change. And these policies must adopt a framework based on equity and justice to transition to a resilient, more developed Latin America. That's my presentation. Those are my references. So I'll be happy to answer any other questions. Thanks.
Thanks so much, Adriana. Very interesting work. Let me highlight Adriana's work is what is called a capstone. So that's why the approach may look a little bit different from the thesis that we have seen, but very, very interesting work, Adriana. We have time for questions and comments.
Thank you.
Any questions yet? All right, I see Bernardo, please go ahead.
Sure, no, before I stop talking, no, Adriana, very interesting work. I mean, looking about the region, could you identify some like successful or unsuccessful stories, countries that have done better or worse in terms of preventing the impact of heat waves and phenomena like this?
Yes, there are some cities that are already starting to implement increasing the green spaces in Brazil, in Central America, all over the region. There are experiences, especially increasing green spaces and access to water to communities. That's very important because, as I said, the region is highly urbanized. And that will prevent people from overheating. I don't remember at this moment exactly which cities, but I know in Brazil, in Panama, there are some successful stories.
Great, thank you. And while people are thinking of questions, I just want to highlight that Adriana is the only Global Health Certificate student this quarter, so we're really happy to have her with Global Health. Fatima also highlights that in the chat box, so thank you for that comment. We still have time for any questions. Anything else for her? Okay, well,
Thank you. Thank you for
Adriana,
having me.
you were very thorough. Thank you very much for that.
No, thank you, everyone. Yes, and this is my last project, so I'm graduating.
All right,
Thanks, Adriana.
congratulations.
Thank
Thank
you.
you.
Congratulations, great work. Then we will move on to the next presentation by Jianu Tamang from the MPH general track.
Johnny, we can see your notes.
Oh, you can see my notes.
Yes.
Just a second. In that case, I will stop sharing. I practiced how to make not to share my notes. So just a second.
Okay.
Okay, let me try one more time. Can you see my notes?
No, we can't. This is perfect. Thank you.
Okay. Good afternoon, all. My name is Gian Tamang, and today I'm going to present my capstone project on a study protocol. And the protocol is about the effectiveness of cascade training using equipped platform and supervision approach among lay health workers for the Thinking Healthy program to manage perinatal depression. And my study protocol is supervised by Dr. Ian M. Bennett and Dr. Amrita Bhatt. So before jumping to my study protocol, I would like to start from the background. And my background, I would like to start from the problem of statement. Perinatal depression is a mood disorder that occurs during and after the pregnancy, and the symptoms can vary from mild to severe, including sadness, anxiety, fatigue, etc., which makes it difficult for a pregnant woman and mothers to carry out their daily tasks. So that has been also from a systematic review study has shown that 19 to 25% of women living in low and middle income countries are affected from perinatal depression, as well as 10 to 15% of women in high income countries. Also, there is a recent study which was conducted in 2018, a treatment gap study, and that has shown that only 13.7% of people with mental disorder receive treatment in LMIC. So why does this study matter? Because I'm interested in mental health, and the prevalence is high. And particularly in Vietnam, I'm interested because I was interested in the work that Dr. Ian Bennett and his team was doing in Vietnam. So looking at there in Vietnam, the prevalence of mental health is estimated to be like 14.2% according to WHO, and also the assessment that was carried out by WHO found that there are limited health workforce, such as which indicates like 0.35 psychiatrists per 100,000 people, such as 0.06 psychologists per 100,000 people, and so on. Likewise, affirmative research in perinatal mental health services carried out by the University of Washington and the Cantor University also found that out of 20 to 30% women who are in the perinatal period, 10 to 15% of women had elevated depressive symptoms. The project I was talking about, the formative research I was talking about, was the project that was implemented by Dr. Ian Bennett and his team. And the name of the project is Global Brain and Nervous System Disorder Research Across the Lifespan Clinical Trial, which started in September 2019 and ended in July 2021. So there are two study questions that I'm looking for through this study protocol. One is if the training innovations such as standardized patient methodology and equipped platform improve the implementation of Thinking Healthy program. And second is, since it's a randomized controlled trial, I will be comparing the intervention outcome in the form of patient functionality and reduce depressive symptoms between two training methods. So my second question would be like, does the patient treated by lay health workers trained in standardized patients show a higher reduction of depressive symptoms than treated by lay health workers trained in the training method? So what is Thinking Healthy program? It is one of the most effective talking therapy for depression. It is also called cognitive behavior therapy that is designed for non-specialist or lay health workers with no previous knowledge or experience on mental health care. It is also an evidence-based psychotherapy model that has been integrated in the routine work of community-based primary health workers. And this innovative model was developed in Pakistan and has been applied in many other countries in collaboration with WHO. Also, it is a supplement to WHO Mental Health Gap Action Program Intervention Guide that provides step-by-step guidelines for delivering 16 sessions grouped into 5 modules, such as preparing for the baby's arrival, early infancy, middle infancy, and late infancy.
5 minutes.
So here we have two training innovation. One of the training innovation we are focusing in this study protocol is the standardized patient methodology. SP is a person who is trained to stimulate the clinical characteristic of an actual patient for the instruction and assessment of clinical skills of student, resident, fellows, and other professionals. And why we are choosing SP methodology? Because many studies have demonstrated that utilizing SP methodology in training and academia is more effective for acquiring competency and enhancing knowledge than traditional method. In addition, it also allows the learner to think critically, interact as a team, and develop communication skills. The other innovation method I'm focusing at is the equipped platform, which also stands for ensuring quality in psychosocial support. It is an online platform of resources also available in an offline format. And the idea of utilizing equip is in our study is to evaluate trainees' competency and provide feedback on their competency result to support their development and modify curricula to the context needs and to the context and the needs. So in summary, our aim was to improve the quality of psychosocial support and psychological training. To measure the common factors of the health workers, equip will utilize the ENACT tool. ENACT stands as Enhancing Assessment of Common Therapeutic Factors. And the ENACT tool will evaluate non-specialist and specialist competency using structured role plays with standardized patient or direct observations. It has 15 item scores, which looks like this. In short, I want to go with this conceptual model. This is the simple conceptual model. Probably among all of the conceptual model you have seen today are in yesterday's presentation. It has 3 components: training of the lay health workers and their competency and the intervention outcomes. Due to the time limit, I will jump to next slide. The method that we are using in this study protocol is the study design consists of clustered randomized control trial, and it will be implemented in 6 clinical sites that are part of Kanto Regional Primary Healthcare System. And our target population are lay health workers, also known as common health workers. Sampling is like with the design effect of 0.5 and alpha 0.05 on one-sided, we have 104 lay health workers, which gives the 81% of power. And to account 10% attrition rate, we will have 114 total sample size of lay health workers. And as the title of the study protocol has said, it is a cascade training. So we will first train 6 training of trainers, which will in turn train these 114 trainers, and they will supervise for the months of 12 months in 12 months to assess their competency. The inclusion criteria we will be using is their the lay health workers minimum education level, as well as no prior training in Thinking Healthy program, and age above 18 years old, as well as willing to complete the training and stay in the study area. Data collection involves self-administered questionnaire, observation interviews, document reviews, and focus group discussion. Analysis on the quantitative part, we will be like testing sample t-test to compare competency level between two arms, multiple linear regression to analyze the patient outcome relationship with the treatment service, 3-point Likert scale coding to compute an agreement percentage to measure the fidelity and budget impact analysis. On the qualitative, we will try to explore the project acceptability and barriers among trainees.
2 minutes.
Since this is a study protocol, we have not conducted any, we have not implemented this study. So the study protocol aims to outline the study design, describe the objectives, methodology, and overall organization to guide the research process in the future. So the data collection has not begun yet. However, the findings that I'm presenting today is from the pilot training that we conducted in late April. And the objectives of this pilot training was to test our approach for the larger study. And we targeted 7 lay health workers from My Khan Community Health Center, which was also part of Kanto Region Primary Healthcare Center. And the training methodology included was presentation, group discussion, exercise, and role play with standardized patient actors. And from the training, we observed that so all the 7 lay health workers were able to meet their expectations. I mean, if you look at their responses, 1 being strongly agree and 5 being as strongly disagree, almost all of the lay health workers has the positive feedback on the training methodology. And we also had the self-evaluation on their confidence on using the inactive skills. And also this chart shows that most of the lay health workers who received the standardized methodology training had built their confidence in terms of providing the services on THP. I would like to thank the committee member who helped me in preparing this study protocol, and also supported by supervising and providing guidance, Dr. Ian Bennett and Amrita Bhatt, as well as the research team that was involved from UW, as well as CITAM, and the study participants, lay health workers who were involved in this pilot training, as well as my family and friends. Thank you, and I'm open for any questions and comments.
Thanks so much, Ianu. Very interesting work, and best wishes for this project. Once it is implemented, we have time for comments, questions.
Yeah, I see a question from Sammy, or hands up from Sammy. Go ahead.
Ianu, great job. So proud of you. Was there any other takeaways from the pilot training that you wanted to expand on?
Yeah, there were certain takeaways that we observed that that was missed during our pilot training, and those were like having the materials or the instruction materials and the prompts for the SP actors, which was missing during our pilot training. Likewise, the pilot training had only 2 interviews for each lay health workers or each trainees. And we did not had like the pre-test and post-test because of the number of interviews we had. So maybe in the future, we will be thinking of 3 to 4 interviews so that we can assess their competency at the first interview and the last interview. And similarly, we also felt, we missed to evaluate the SP actors, how they performed. So maybe that we will have some checklists to evaluate the SP actors as well in the future.
Great, thank you. You have a question from Deepa, who says, wonderful presentation. I wonder if you could speak to local partner input on the protocol. What was that like? So
the local partners, we have not spoken yet because this is just in the formulation phase. Maybe when this is finalized, we will be speaking with the local partners, like the primary healthcare settings that are existing primary healthcare setting in Kanto region, and we will be taking their opinion and feedback.
Great, thank you. And next question is from Steve, who says, nice presentation. What role will you play in the fall study?
So sadly, I will be graduating this year, but I would be very interested to continue my role as a participant in this research. So I will be continuously following up with Dr. Bennett, or if that's something even possible, then I would like to be in the part of the team in the future when this project is going to be implemented.
Great. And for the last question, and if you can answer this in 2 minutes, Bernardo says, great work. You present your sample size / power calculation. On what variables is it based? And what would be your main outcome and what size of effect would you expect? So
we are looking at effect size 0.5, which is moderate change based on Cohen's design effect. And I use the R Studio to calculate this power. The formula in R gave me 81%, which gave 52 health workers in each arm. And what was the questions related to outcome? Sorry, I missed that part.
Let's see. What would be your main outcome and what size of effect would you expect?
So the outcome our primary outcome is the competency level of the community health worker, and the secondary outcome is patient health outcome, like improved function and reduced depression symptoms. So for both of these, there will be a 12 months follow-up through supervision, and the training of trainers will act as a supervisor and supervising the trainees who receive this TSP training through standardized patient methodology, and they will use the equipped platform to assess their competency score in every quarter. And from that point, we will measure how they have achieved in terms of competency, as well as we will be going through the PHQ-9 that was being conducted, or the screening that has been taken by lay health workers in their commune areas, and measuring the outcome versus the competency like that.
Fabulous. Thank you so much. Thank you, Janu.
Thank you.
Thanks so much, Janu. Great work, and really best wishes in this adventure. We would move to the next presentation by Moira Majaha.
Can you guys see my presentation? I think my screen just froze.
Yes. Yes.
Yes.
Okay, there we go. All right, hello everybody. My name is Moira Majai, and today I'm going to be presenting my thesis titled Understanding the Impact of COVID-19 on HIV Care Among Adolescents and Young Adults Living with HIV in Kenya. This thesis was supervised by Dr. Njuguna and Dr. Bema Sophie. I would like to start by acknowledging the fact that I went into this study as a cisgendered 26-year-old female who has both lived experience in Kenya as well as personal experience with adolescents and young adults living with HIV, and an overall involvement within the study was through data analysis as well as currently manuscript writing. So jumping right into a quick snapshot of Kenya's HIV epidemiology, we find that approximately 190,000 adolescents aged between 10 and 19 are currently living with HIV. This is a highly vulnerable and highly at-risk population group, as evidenced by them making up almost 42% of new infections yearly. They are also characterized by low clinical outcomes, as seen in 2020 with, of all those on ART, 33% of them were not virally suppressed. And as a result, because of this risks and vulnerability, there's constant studies being conducted within this target population. And my thesis is actually nested in a bigger standard trial that is known as Adolescent Transition to Adult Care for HIV-infected adolescents in Kenya, here on referred to as ATOUCH. So looking into the COVID situation in Kenya, right immediately as prevention mandates were put into place, the Ministry of Health went ahead and introduced new recommendations in an effort to mitigate unintended consequences on HIV services. Some of the recommendations made included ART being dispensed for 3 months, regardless of age and viral load, as well as the use of differentiated ART delivery methods. It is important to note that prior to the pandemic, guidelines did not recommend the use of differentiated treatment models, such as community-based ART groups or adolescents younger than 20 years old. So with so many of these social as well as service delivery changes, it was inevitable that HIV care was going to be impacted. And as a result of that, I was interested in addressing mainly 3 questions through my thesis, which was what was the impact of COVID, of the pandemic on medication adherence, as well as clinical services, access to clinical services among adolescents and young adults. And as well, what was the effect of mental health issues experienced during the pandemic on medication adherence. So to assess these questions, I used a mixed methods approach with the ATOUCH cohort. And there was a total of 20 study clinics at which the COVID questionnaire was procured via telephone. In total, we had about 1,066 responding participants. To further understand the lived experiences during COVID, in our exit interviews, we included questions asking about that. And in total, we had 71 interviews that were conducted in the interviewee's language of choice and then translated and transcribed in English. Data analysis was conducted in RStudio as well as Atlas T, and currently I am merging both my qualitative and quantitative data using a triangulation technique. So for my quantitative analysis, I utilized a multivariate logistic regression in order to be able to determine my odds ratio with mainly 3 main outcome variables of interest, which were medication adherence, access to clinical services, as well as reporting of depression. And then we included independent variables that included age group, gender, entry point, as well as primary caregiver. To analyze my qualitative data, I used a combined deductive and inductive approach, and all codes ended up falling into main categories, which is COVID influence, looking at factors that influenced adolescent experiences, as well as COVID outcome, which is the descriptions of the actual effects of COVID. So looking at overall demographic characteristics, most of our participants were made up of females with our mean age being of 20 years. Overall, our biggest contribution of participants came from comprehensive care center clinics at about 67% participants. And finally, for our adolescents and young adults, their main source of support were their parents. Starting off on medication adherence, we found that overall it was relatively high, with only about 3% of participants having reported missed a single dose in the past 7 days at the time of our survey. It is important to note that though not statistically significant, older adolescents were more likely to adhere than young adolescents. And then when really looking at those who reported missing medication, a noticeable theme was the loss of will and desire to engage in care, as evidenced by this quote here that states, "I was not taking drugs totally. I just didn't feel like taking drugs. And then I stayed for 3 months without coming to the clinic." It is also important to note that even for participants who are adherent, some frequently raised common concerns were about transportation and drug supply that could ultimately disrupt their adherence.
5 minutes.
Moving on to clinical services, we found that overall about 6% reported having challenges accessing clinical services. And then I want to take time to explain the reason that we decided to also look at accessing to ART separated from other clinical services, such as consultations, lab work, as well as peer support groups, primarily because if you did have access to a clinic, it did not mean that you also had access to actual ART medication, as evidenced in this quote where they state that even if the individual goes to the clinic that's at her house, with current shortage of drugs at some facilities, they may fail to give her the services because drugs are scarce. So there is that discrepancy of being able to continuously access clinical services while also having issues accessing ART. And then overall, we found that age and entry point were associated with challenges to accessing clinical services, with older adolescents and CCC patients experiencing them more. When looking at impact of COVID on mental health, we found that experiencing frequent depressive symptoms such as anxiety, loneliness, and constant worry was a recurring theme among adolescents. As we see in this quote that states, "For me, I just think mentally because you're just cautious of everything you do. Sometimes I worry. I have my own worries constantly to care about." So overall, we found that older adolescents as well as females were more likely to report feeling depressed during the pandemic. And finally, taking a look at the impact of mental health on medication adherence, one of the biggest depressive symptoms that was statistically significantly impacting adherence was loneliness, with adolescents who reported being lonely being less likely to be adherent to their medication. One of the reoccurring themes from our interviews that we found was that there was a disruption of essential mental and social support networks that ended up consequently resulting in disengagement in care, as evidenced by this quote that states, "Now I don't even meet with my friends, so I don't have people to share with what I'm feeling, what I'm going through, because when you come, you find yourself all alone. I have never met any teenager whom I can talk to or just ask, how is COVID taking you?"
2 minutes.
So going through our key findings, we find that despite COVID prevention measures, adherence remained relatively high among adolescents and young adults in Kenya. Unexpectedly, though, what I was not expecting was that adolescents and young adults had minimum issues accessing clinical services and refilling prescription on an overboard level. And then we also found that older adolescents are more likely to experience clinical access challenges, but they're also more likely to be adherent to their medication. And finally, we found that mental health plays an essential role in medication adherence. It is important to note that there are a few limitations in this study, primarily that our COVID questionnaire takes on a very cross-sectional approach, and therefore that raises issues with temporality. And then questionnaires are self-reported, so that introduces response bias in our result, and then also acknowledging the fact that we utilize a very high-level overview interpretation of mental health. So in conclusion, the study, we see that adolescents and young adults HIV care was impacted in different ways. However, there were some frequently shared concerns, such as lack of support groups and fear of ART stockouts. It is a hope that this study contributes to growing literature and lessons on improving care, and some recommendations include integration of mental health services, as well as revision of guidelines on differentiated service deliverance for adolescents younger than 20 years old. And finally, just to acknowledge that this would not be possible without the attached participants and research team themselves, as well as my thesis committee members and Dr. Edward Kasna for the continued mentorship in the process, and finally, family and friends for all the words of encouragement. Thank you.
Great job. That was really, really amazing. Very strong. Any questions for Moira? All right, I'm going to start us off with Deepa, who put in a chat box. Good job, Moira. Just wondering, would you recommend using a different term than mental health with adolescents based on your experience?
I think one of the most difficult things that I had in this thesis process was really, because I am no expert in mental health, so I was trying to really figure out how to categorize and use an overarching word for like the symptoms that we were asking. So we were in our questionnaire, we were asking, how often have you felt worried? Have you been anxious? Have you been lonely, right? And so all of those sometimes are seen as depressive symptoms, henceforth why the overarching outcome was reported depression. So it's still in the works, still deciding, but I think for now I'm going to be sticking with mental health as the overarching umbrella term.
Great, thank you. Question from Claire. Claire, please go ahead.
Hi, congratulations. That was such a great presentation. I wanted to ask you a bit about your method. So I'm really happy that you chose to do a mixed methods thesis, because I was your TA for PHI 513. You did a really amazing job integrating the two. And I see that you have a lot of convergence between your Qual and your Quant methods. And I really like how you presented this work to us, showing us the Quant on the left side and the Qual on the right side. And I hope you had a great time doing that work, but I'm curious to hear from you. What plans do you have to think about this?
Oh, you got cut out, Claire.
Stories.
Hello?
Thanks.
Oh, you got cut out. I didn't hear the last part of your question. Sorry. After what plans do you have?
If you want to type your question in, I'd be happy to read it out loud.
Sorry, can you hear me now?
Yes.
Yes.
Yeah, sorry, I'm having internet issues. My main question was, what plans do you have for disseminating this amazing mixed methods research for both the Qual and the Quant to the Ministry of Health? Thanks.
Yes, so we're currently looking into different journals. There've been like some calls from adherence journals that I'm hoping once I finalize my manuscript, I'll be able to submit those for publication.
Great, thank you. And Bernardo, do you want to ask the last question?
Yes, no, I mean, very interesting work. Congratulations. I mean, my take from your presentation is that even in such an adverse environment, it seems that adherence to treatment got not that affected by the COVID. What is good news? So how do you explain that? This is like a successful story. What they did to keep that rolling?
Yeah, I think I would probably attribute it to mainly two things. Like I mentioned that there was a shift in service delivery with many of them receiving 3 months worth of ART. So I think that alone was able to keep them adherent as they had full supplies for 3 months. However, also, as I mentioned, that we did see that like older adolescents tend to be more adherent to their medication. And I think this might be attributed to the fact that like, as you grow older and you understand more health behaviors, you tend to have better body autonomy as well as self-efficacy in terms of your own HIV care. And I think that's what might have been playing, as well, taking into considerations that when our interviews, we did see a lot of them being like, they were fearful of COVID, a couple of them talking about how they thought if they had both viruses, it would amplify bad health outcomes. Therefore, they were driven to stick to their medication as a whole, as a total. So those are some of the factors that might be taken into consideration in terms of the success story.
Perfect, thank you. That's all the time we have. Thank you so much for that really, really strong presentation.
Thank you, guys.
Great, Maura, thank you very much. And then with this, we would move to the last presentation of this first block of today by Christina Masumder. Okay, Christina, if you want to go ahead, please.
Christina, you're on mute.
All right, I'm ready. Hello, my name is Christina Mazumder. I'm a second-year MPH student in the Department of Global Health. The title of my thesis is Understanding Factors that Influence Pregnancy Self-Test Use Among Women in Western Kenya. Due to my positional and power dynamics as a European American graduate student, educated by a Western institution, I cannot attest to possess the intellectual and cultural tools necessary to interpret linguistically and contextually what the women in this thesis are willing to describe. I therefore utilize the expertise of local Kenyan research staff to conduct individual semi-structured interviews in the local dialect while I participated in the analysis of transcripts post-English translation. I additionally acknowledge my privilege of living in the global north, where home pregnancy tests are well promoted, easily accessible, and considered affordable to much of the population. I would additionally like to acknowledge these individuals who were involved in the data collection process and all members of the PRIMA study team. Without their efforts, this thesis would not have been possible. The premise for my analysis is based on previous work conducted by former University of Washington graduate student Nina Ngaga, who investigated the prevalence and correlates of pregnancy self-testing among women who were enrolled in a study called PrEP Implementation for Mothers in Antenatal Care, or otherwise known as the PRIMA study. The PRIMA study was based in Western Kenya and aimed to find best approaches for implementing PrEP medication within maternal and child health clinics in Homa Bay and Siaya counties. What we know from previous studies is that pregnancy self-testing is associated with early antenatal care presentation. However, Ngaga's cross-sectional analysis showed modest use, where only 22% of the women reported using a home pregnancy kit. And according to Ngaga's research, the most reported reasons for non-use of pregnancy self-test included not thinking it was necessary, lack of knowledge, lack of money to pay for the test. And recommendations were made to build upon this research to further understand the reasons reported for non-use. My research question asks the following: what factors influence women's decisions around pregnancy self-test use during early pregnancy? Methods included purposefully sampling 48 women who participated in the previous PRIMA study. Women were stratified based on pregnancy self-test use and non-use and whether they presented for antenatal care in the first trimester of pregnancy. Interviews were based out of 4 health facilities located in Homa Bay and Siaya counties. Individual interviews were conducted by our local Kenyan study team, who performed the interviews in participants' language of comfort, then later translated the transcribed the content into English. Featured here are some questions asked during the interview that pertains to pregnancy self-testing. Due to the COVID-19 pandemic, interviews were conducted remotely using mobile phones set on speaker function with a recording device nearby to capture all content of the interview. My qualitative research process involved selecting 20 transcripts to review from a randomized list of 48, which was stratified by users and non-users of pregnancy self-test. I then coded the 20 transcripts with the help of 2 co-coders. The codebook was developed using the Conceptual Model for behavior change, which is a framework that consists of 3 constructs: capability, motivation, and opportunity, where capability refers to an individual's psychological and physical ability and has 2 subtypes: physical capability and psychological capability. The second construct, motivation, refers to conscious and unconscious cognitive processes that direct and prompt behavior. The subtypes here are reflective motivation and automatic motivation. Opportunity focuses on external factors that make the behavior possible, such as the subtype physical opportunity, which allows an individual to pay for a home pregnancy kit and arrange for transportation to access the kit. The other subtype is social opportunity. An example of this is social norms or social acceptability for women in the community to use pregnancy kits. Conceptual Model says that when these 3 COM factors interact with each other, they have the capability of producing a change in behavior. I also use a thematic analysis approach, which is a method for analyzing and describing qualitative data through a process of identifying repeated patterns. I used recurring responses from the data to produce themes that represent the women's experiences and perspectives towards pregnancy self-test use. Here are some of the findings that describes the community of women who participated in the study. Mean age was 30.5 years, mean number of lifetime pregnancies 2, 55% of the women completed secondary school or higher, and 70% of the women reported being employed.
5 minutes.
And here's what I learned about this community of women through coding the transcripts. There was an overwhelming theme of mistrust that emerged and presented itself in a multifaceted way, where lack of trust in the home pregnancy test intersected with decreased desire to spend money on the product, spend money on transport to access the product, and outweighed the risk of asking male partners or family members for money to purchase the product. This ties into Combi's construct of motivation with the subtype of reflective motivation, which is motivation that involves conscious thought processes, such as plans and evaluations. Here, one 22-year-old female expressed, "I did not test by myself. I knew that after I was tested in the lab, then that was the truth. I knew that if I test myself, it would cheat me. I mean, I cannot believe it, so I went to the doctor." The second theme that factored into a reason for non-use of pregnancy self-tests, lack of awareness regarding how to use the product, where to access the product, and the ability of the product to detect a pregnancy as early as the first missed menstrual cycle, which ties into Combe's construct of psychological capability and is defined as mental functioning, such as understanding important components about the kit, including where it can be accessed. Other reasons of lack of awareness were related to unawareness of physical signs and symptoms of pregnancy, which contributed to some women being unaware of their pregnancy status. Without this awareness, the women were not internally or automatically prompted to seek out the kits, and is a great example of Combe's construct of automatic motivation. Here, one 38-year-old female says, "It is because I do not know how to use it, so I will go to the hospital." And another woman states, "I don't even know where they are bought or even how to use them." For the final theme, cost was reported as a barrier, and as mentioned prior, cost intersected with trust. Women expressed that pregnancy testing can be handled for free at local health facilities, so why pay for a kit if you can avoid the expense? This ties into Combe's construct of physical opportunity that involves financial material resources related to the ability of accessing pregnancy kits. And one woman here says, "I did not want to go to the chemist because of the expenses of using money to buy a pregnancy test kit, because I knew at the hospital the services were to be done for free." Based on these findings, here are some recommendations. Employ health and community health workers at local pharmacies to build trust towards product. Normalize use of pregnancy self-tests through media campaigns and radio advertisements. Engage facility staff to promote self-testing, educate women on early signs and symptoms of pregnancy, improve community knowledge of benefits for using pregnancy self-test, and pharmacies to supply pregnancy kits at subsidized rate or free of charge. In conclusion, trust awareness and cost impact pregnancy self-test use. Home pregnancy kits can be a great tool for linking women to antenatal care services during early pregnancy, where many benefits are offered, such as infection screenings, PrEP initiation, nutritional counseling, and assessment of mother-baby well-being. I would also add, as a prior user of home pregnancy tests and as a healthcare professional myself, I can attest that these kits arm women with necessary information needed to make life-sustaining decisions, and therefore investing in making this tool available to all women, regardless of socioeconomic status, would be a great contribution to health equity. Thank you for listening to my thesis presentation. I would like to thank my entire thesis committee, Melissa, James, and Claire, for their thorough guidance and mentorship, the Prima study team for making this opportunity possible, our Kenya-based colleagues for their challenging work and expertise, and the women who are willing to share their unique and valuable perspectives on pregnancy test use within their community. I now have some time for questions.
Thank you very much, Christina. Great presentation and great work. We have time, as you said, for questions, comments.
Okay, Christina, great job. First question is from Bianca, who says, "How much do pregnancy tests cost in Western Kenya, and what type are available?"
Sure. Usually they're using the urine dip type pregnancy test, and I would say due to Kenya's devolution of primary healthcare practices to the county level, this has led to variability in procurement practices. And because of county level procurement varies so much, smaller orders might lead to higher prices, but generally at the pharmacy level, they can be purchased from anywhere from 30 cents to $4 per test.
Great, thank you for that. Next question is from also one of your peers, Deka, who says, "Amazing job, such a well-versed and concise presentation. I do have one question. Did you look at reasons why women used a pregnancy test?"
Yes, we actually looked at reasons why they use and why they don't use, and just for purposes of this 10-minute thesis presentation, we chose to focus on reasons why women don't use and ways to kind of troubleshoot or problem solve in that area. But for my entire, I will be including the reasons why women use pregnancy tests for my full finished thesis product.
Wonderful. We still have time. Any other questions for Christina? Bernardo, please.
No, Christina, congratulations. You were mentioning these issues of availability. How is the situation in this context? Are these tests distributed for free? You have to buy them? How expensive? What is pretty much easy or difficult for a person to get these?
Yes, so you have to purchase them. They're not free currently, and they're usually easily accessible at community pharmacies. And sometimes women, they already know that testing can be done for free at the health facilities. And so for women on a limited budget, that could be a source of like financial strain. So if they know that there's another place they can get it done for free, they will go there, but that also contributes to delays. And sometimes they can just kind of put it off depending upon the location or how far away the free testing is from their homes versus local pharmacies, which could be closer to where they live. But yeah, they're about 30 cents to $4 per test kit, just depending on the pharmacy.
Great, thank you. Well, Christina, there's a lot of congratulations and great presentation remarks in the chat box. So I recommend that you take a look at that. I believe that's all we have, and we are doing amazingly on time. We're like actually right on time. So Bernardo, do you mind if I take it from here?
Of course, go ahead, Nura, please.
All right. Well, thank you all so much for coming to the first half of our thesis and capstone presentations for this spring. So it is time for a nice little break. So we've got 6 more presentations after the break. So please return a little bit before 2:15 for the next batch of presentations. Get some water, get some food, and come back with a bunch of energy. All right, thank you. All right, welcome everyone from break. Let's start to log back in and get back in the space for the thesis and capstone presentations. Deka, I want to confirm that you're here, correct?
Yes, I'm here.
Okay, I've given you access if you can share your screen.
Okay, are you guys able to hear and both see my screen?
Yes, we can hear and we can see you.
Okay.
Beautiful first slide.
Thank you.
Perfect. Well, welcome everyone from break. I hope you got some food, some water, was able to stretch. We are really excited to get into the second half of the presentations. Deka, please go ahead and kick us off.
All right. Hello, everybody. My name is Deka, and the title of my thesis is Healthcare Provider Perspectives on the Benefits and Barriers of Integrating PrEP into Family Planning Services in Kenya. My thesis chair is Dr. Kenneth, and also one of my community members is Dr. Kristen. So as we begin to navigate this thesis, I'd like to share a bit of positionality. I have ties to the East African region. However, that is the only connection I have to this project. By acknowledging my specific position in this context, specifically HIV research, I know that my positionality allows me to review this data set and understand what my potential biases may be present and reflect on those when considering my interpretations of the work. So let me begin by sharing a bit of background. Women account for a disproportionate number of new HIV infections in Africa. More than 1.7 million persons get newly infected with HIV annually, a majority in sub-Saharan Africa. Young women of childbearing age represent a disproportionate percentage of those new infections, and Kenya is a specific area of focus because it has the third largest HIV epidemic. PrEP is a proven HIV prevention strategy that women can independently control. When taken orally, it reduces the risk of getting HIV from sex by up to 99%. Currently, PrEP is accessed through HIV clinics, but may not be meeting the needs of the women who need it the most. FP clinics are highly accessed by young women and offer an opportunity to integrate HIV prevention and sexual and reproductive health services. By bridging a gap between PrEP access and family planning clinics, we are able to identify a safe care setting to provide routine care and prevention methods. My thesis work is embedded in the FP Plus study. That study is an open label implementation science project that catalyzes the integration of comprehensive HIV prevention and PrEP care services for adolescent girls and young women, accessing routine services at a public health facility with established family planning clinics in Kenya. Integrated services can ensure that all people living with HIV have access to family planning services that support their fertility desires and choices. The study design chosen was a step-wedge design, and we interviewed healthcare workers from step 1 sites. And also the step-wedge design basically entails, it involves a collection of observations during a baseline period in which no clusters are exposed to the intervention. By anchoring PrEP delivery to care settings, it will provide a one-stop shop approach because of the integrated services. To fill this gap, the study provides provider training, technical assistant, and county supervision. My role in this thesis is to evaluate what that integration is looking like and identify what works and what doesn't. I have 2 research questions I aim to answer in this thesis. The first is, what are the key influences on the feasibility and acceptability of early integration of PrEP delivery in FP clinics from the perspective of healthcare providers? Secondly, what are the recommendations for improving the integration of PrEP into family planning clinics? Our assessment is grounded in the Consolidated Framework for Implementation Research. CFIR is a meta-theoretical method from implementation science that was developed to guide systematic assessment of multi-level implementation contexts to identify factors that might influence intervention implementation and effectiveness. So we conducted a qualitative evaluation of healthcare worker implementation experiences, and we had providers at 12 family planning clinics in Kisumu County that were trained on PrEP and asked to integrate PrEP into routinely provided FP services at each facility. Women attending family planning clinics were screened for HIV risk, counseled on, and offered PrEP, and offered enrollment into the study regardless of their PrEP use decisions. So the eligibility criteria for the healthcare workers is quite simple. They had to have received training by the study team, currently provide or previously provided integration, and greater than the age of 18 years old. We anticipate recruiting around 3 to 5 healthcare workers per site, and again, we have 12 facilities. Our in-depth interviews were conducted using a structured discussion guide informed by the CFIR wiki site.
We interviewed 16 providers and conducted 16 IDIs from 4 facilities in wave 1, and these were led by trained social scientists. Each interview lasted about an hour and were audio recorded and transcribed. These discussion guides explored healthcare experiences at work while delivering PrEP. The remaining questions in those IDIs elicit perceptions on workload, self-confidence, and various opportunities in the workplace. Those questions were asking healthcare workers their thoughts on the overall climate within the facility they are employed in, their original impressions of integrating PrEP in the beginning, how healthcare workers feel after 5 months of integration, and current challenges that have popped up. And lastly, what other forms of assistance that supported integration and recommendations for future changes and adaptations. Our data analysis comprised of 3 main steps: the creation of our codebook, which assisted in transcripts being independently coded and reviewed by another coder using the Atlas TI-9 software. And lastly, the data we analyzed to identify determinants, highlighting barriers and facilitators to integration. After coding is complete, we will use CIFAR to link key concepts, examine coded sections of the transcripts, as well as generate a wide variety of themes. The team will also synthesize data to understand concepts that comprise the network of themes regarding the healthcare workers' perceptions of PrEP integration.
5 minutes.
Thank you. So there were many CIFAR constructs that influence healthcare workers' perceptions of PrEP integration into family planning clinics, and I will be highlighting the few that were the most influential. A CIFAR construct that positively influenced healthcare workers' perceptions of feasibility was readiness for implementation, more specifically the access to knowledge and information. And that basically describes the ease of access to digestible information and knowledge about the intervention and how to incorporate it into work tasks. And so healthcare workers described the training as extremely critical for the staff, and these training sessions allowed healthcare workers to gain more knowledge on proper integration of PrEP into family planning clinics. In addition, they were able to see the work that they were doing being reflected almost immediately. For example, one healthcare worker described how they were first, we are preventing unwanted pregnancies. At the same time, we are preventing the women from acquiring the virus. Yes, so we are preventing 2 things at the same time. Then it is a one-time approach. When a woman comes, you will finish everything on that visit until the next time she comes for another refill or another session. And so this is a direct reaction of the assistance that they're providing. Our next construct is reflecting evaluating, and this code highlights traditional forms of feedback, such as qualitative feedback and anecdotal stories of success. And for example, and again, I will be discussing community education. So for example, one healthcare worker stated, yes, so it is better community health volunteer because they are well known in the villages where they come from, so they can create demand. So somebody comes knowing what they want, a service which is also available, and they will come saying, I have been referred by a community health volunteer, because they also even write referral letters, you see. So that would help if we involve them. And so by engaging the community and mobilizing community health volunteers, you're expanding the amount of people you can assist. Finally, I will be discussing the CIFAR constructs that negatively influence the integration of PrEP into family planning clinics. First, healthcare workers describe the construct of outer setting as negatively influencing integration, more specifically the sibling code of patient needs and resources. And in our analysis, healthcare workers felt that stigma, increased workload, and lack of staff contributed to the challenges they faced. One healthcare worker stated that one of the challenges they faced was a lack of staff, and I quote, "We had a big challenge with that because only one nurse was trained and was not there at the facility, so that made work a bit difficult." And the next construct, again, I will be highlighting that influenced healthcare perceptions of was available resources. Sorry, we're readiness for implementation, and the sibling code was available resources. And this described the level of resources dedicated for implementation and ongoing operations, including money, training, education, physical space, as well as workload. And one healthcare worker stated, let's say, for example, now a client came to the family planning room and she wants PrEP. You just saw the queue that was there. There's a COVID vaccination, the usual immunization. The MCH is full. There is only one nurse, so that is a challenge. The client will wait a long time and will excuse herself that she will return another day because she has waited a long time, and yet you had to convince her to take PrEP, so you lose the client. So that's a really, really big challenge.
2 minutes.
Thank you. And so we have 3 main recommendations from the healthcare workers, and I will be reading these out. The first is to increase staff. As we've read in the previous quotes, a lack of staff often has a higher workload. So being able to hire more staff will really be able to have the nurses to not be as stressed. The second is to identify an appropriate amount of training based on previous knowledges. Healthcare workers have stated that if they've integrated before, that they should get a different training than those who haven't integrated. And last, mobilizing community education by the community health volunteers. And so as far as acknowledgements, I really would like to thank both Kenneth and Kristen for really helping me on this project. I really, really appreciate the assistance. And also I would not have been able to do this without the team in Kenya and all the participants involved in the study. And I'd like to give a special thanks to the ICRC, or the International Clinical Research Center. Thank you, everybody.
Great, Dika. Thanks so much for this clear and very interesting project. We have time for questions and comments.
All right, so we've got a question from Asha who says, incredible. What was the most surprising thing you learned from your IDIs?
I think one of the most surprising things I've learned, because with our discussion guide, we discussed things of like overall climate to like workload. And so when reading some of the health coworkers, they would just mention that like the workload was so high, but the fact that their coworkers made it better was pretty surprising to me because they wouldn't be as stressed. So that was really, really interesting. Also, the emphasis on community mobilization. I know HIV is a big stigma, especially in this country or in this region. And so the fact that nurses don't see themselves as like a community health volunteer, although they are part of the community, and that they should actually reach out to local community members to really destigmatize HIV and PrEP and integration of family planning services. So that was really interesting. Thank you.
Great, thank you. Let's see, a lot of congratulations. All right, one question from Luna, who says, great presentation. I wonder why you chose the CFIR framework to guide your work.
Yeah, great question. So we chose CFIR. Well, originally it was nested in the Family Planning Plus project, which my thesis is embedded in, but also CFIR really allows you to highlight the barriers and facilitators to any intervention. And so when you have the main domains, it starts from like intervention characteristics all the way to process. And so those sub-constructs really allow you to, when you're reading the transcripts, highlight major barriers and facilitators. And so that really, by applying that code book to our transcripts, it really allowed me to identify like workload and stigma as main challenges, but also facilitators such as like training and so on and so forth. So that's why we chose CFIR.
Thank you. And your last question, this is from Bernardo, who says, great presentation. Based on your results, logistically, how feasible do you think it is to conduct this integration? Do facilities have the capacity to do this?
I think it really is feasible when you're doing amazing thing by integrating PrEP into family planning services by destigmatizing that, but also I think facilities do have the capacity to do this only if they were able to mitigate the major barriers that I highlighted in the thesis, such as like staff and workload. And in a perfect world, you know, that would be amazing and it would be a great facilitator. So I think they do have the capacity, just more so finding the proper staff and like identifying proper days for training to those who've integrated before and those who haven't previously. So thank you for that question.
Great, thank you. I guess actually we are at time. Deka, thank you so much for your really wonderful, wonderful presentation. Good job.
Thank you.
Very nice work. We would then move on to the next presentation. It's by Bianca Graves. Bianca, please.
All right, hello, can everyone hear me? So
yes, it's a little low. If you can try to speak a little louder, that would be great.
Okay, can you hear me now? Okay, I put some bass in that voice, you know. So good afternoon, everyone. My name is Bianca Graves, and my thesis project is Tribal Acceptability of Birth Control, which is the over-the-counter birth control study for American Indian women and adolescents in King County. My chair is Dr. Beth Ribben, and my committee members are Drs. Myra Parker and Dawn Downing. So this is my positionality statement. I am a BIPOC individual. I am first generation, but I will attest that I am not American Indian or Alaskan Native, which is my study population. So it definitely does shape the way I view my research and how I do my work. And this is the organization that I am in partnership with, which is Uplift International. It's based in Seattle, and it advocates for the right to family planning, both in the United States and across the globe. This current project is nestled into a larger multi-site project that is going to help inform the implementation of over-the-counter birth control for American Indian and Alaska Native communities in Washington state as a whole. And I just wanted to start off with a very brief and very small definition of what family planning is. Based on the World Health Organization, it is essentially just giving people the right to plan if they want to have kids, when they want to have kids, and then also how many. And there are a lot of benefits in being able to do so. And then I also want to define what over-the-counter birth control pills are. So this will refer to any type of hormonal birth control method, usually taken orally in a dose, being available without a prescription, meaning people can go pick it up similar to how you can pick up Tylenol at 7-Eleven or maybe a vending machine at the airport or a grocery store. So it will take away that barrier of having to go to a physician first in order to access some family planning. And here's some general background for my research. So AIAN, which I use for American Indian and Alaskan Natives, experience significant health inequities. A lot of this inequity is rooted in long structural violence and settler colonialism and the history of displacement of Indigenous people by Western forces. So we can go very far into history, and then we can also go a little bit closer. So a lot of this disparity puts them at a high risk of poor health outcomes because they have limited access to quality health services, limited access to culturally competent physicians, issues sometimes obtaining health resources and proper health information. And there is a very scary history and high rates of violence for AIAN women. The National Institute of Justice reported that of 97% of all Indigenous women in the states who report violence, 97% of them, the violence was perpetuated by a non-Indigenous person, meaning that there is a lot of violence in this community that's being perpetrated by people outside their racial and ethnic group. Due to that long history of violence and marginalization, we can see that a lot of urban living American Indians do not have access to their federally funded Indian Health Service, and then also have access gaining other forms of health insurance like Medicare, Apple Health. The teen birth rate is almost twice as high as non-Hispanic whites, and then there is a high rate of unintended pregnancy and abortion. And another alarming issue and why this is important is urban AIN teens report low contraceptive use and even lower condom use. Another interesting piece of information is they tend to have sexual activity younger with older partners. So that can also increase their risk. This is just an example of the disparities that a lot of AIN, what mothers face in America. Their maternal mortality rate is about 2 to 3 times higher. The only group that is higher than them is Black women. So you can just see that there clearly is a health disparity here. And I want to say why over-the-counter birth control. It is widely available in over 100 countries, and a majority of American women and teens have already reported interest in it. But from our knowledge, this study is the first of its kind, specifically focusing on Indigenous women or American Indian Alaska Native women and their interest on birth control and over-the-counter pills. It is relevant because the US FDA is voting soon or deciding to approve progestin-only pills over the counter. And there are already options readily available. So these are my thesis aims: to identify birth control preferences and over-the-counter birth control acceptability in King County urban Indian communities, to identify perceived and institutional barriers for these women and adolescents to accessing birth control, and then also determine favorable delivery mechanisms, such as vending machines or a corner store, other ways to deliver it to the population to avoid those disparities. Going to the methods. So the setting is King County. There's only about 40,000 people who are AIAN. And then when you think about women or the other people, that's less than 1% of the population. And a lot of structural violence against this population has driven this population into higher rates and incidences of poverty. So this is our recruitment process. It is entirely online. So we're using social media and posters and print media to recruit people. We're pre-screening them on a survey, also online, e-consent. There's a survey and then there's a follow-up for the later part of the study, which is the focus groups and in-depth interviews. Here's the inclusion criteria. They just have to be of reproductive age, be able to become pregnant, willing to give digital consent, and then also identify as American Indian, Alaska Native. So this is the research methods right now. We're going to use data collection via REDCap and then data analysis on R with summary stats, cross-tabulation, and bivariate regressions. So just candidly, due to the extremely low participant engagement, the project is still in data collection. What we will do when we get a little bit more participants is use variance to show just the demographics, their preferences, access, and solutions, and then potential benefits as well. And then this is the discussion section. Like I said, this is the lessons learned because I do not have results or recommendations to give you right now, but I have worked for the last 8 months developing every single piece of study material. So I drafted the consent forms, the interview guides, the study. I drafted the first round of the IRB application, and it was my first time doing so. And then I'm also going through the woes of being the first part of a multi-part study, whereas many people are on the second or third part of a multi-part study. So I'm going through the primary data collection woes. I'm going through the woes of dealing with a key population that is very small, a key population that some people consider statistically insignificant. And that's where a lot of literature is lacking. So with this process and me going through the woes of primary data collection and in this survey, I have truly learned to be flexible, to change things, to not be afraid to modify things and to see how can we reach this population better. And then here are limitations to the study. Due to COVID-19, we've had a difficulty with recruitment. A lot of the community centers that we have posted, they're just not getting as much foot traffic. And then also a small research study population equals a very small sample size. So candidly, right now, it's under 5 people that currently have actively done it, and it's been open for about a month and a half. So I'm hoping to get more people over the summer to be able to analyze the data and show results. And then I just want to acknowledge Drs. Riven and Parker. Dr. Parker is Indigenous herself, and she leads the 7 Directions Research Center. So I've learned so much about Indigenous public health. I also want to say a special shout out to the interns that have been helping us recruit along the way, Sarah and Misha. I want to thank Uplift International and the Department of Global Health. And that is the end of my presentations, and now I'm open for questions. Thank you.
Thanks so much, Bianca. Very interesting project. We have time for comments. Any questions?
Great, thank you, Bianca. So we have a question from Leah in the chat who says, this is a super cool study, Bianca, and congrats on the IRB. What adjustments have you made to your recruitment strategy along the way, given the low participation?
Okay, yes, thank you so much, Leah, for your question. So some of the adjustments we've made is making it easier. So initially, the participant had to call the research study number and then talk to us. We would screen over the phone, and then they'd be sent the work. But we realized a lot of people, especially if we want to target adolescents, they don't like using the phone. So we sent an IRB addendum to make sure that there's a completely remote screening process. And then we can send them information entirely remote without having to speak over the phone with them. We also have an email as well, and other services, and we're using social media as well. So before we were only sticking to Facebook, and now we've moved to Twitter and Instagram to try to appeal to the younger audience.
Great, thank you. And another question from Deka, who I feel like is similar to, you perhaps addressed this, but how are you trying to increase engagement?
So yes, increasing engagement is just being very persistent. We have been contacting our network of other Indigenous or American Indian community centers and orgs, Planned Parenthood as well. So it's been a lot of interpersonal networking to try to get the study just like more readily available to people so they know that it exists. And then also another way we're trying to increase engagement is just being more interactive on the internet. So just having more of a greater internet presence so people see there's activity to get more of like a paper trail, I guess, going with our research.
Awesome. I just want to plug in that Beth said, great job, Bianca. Remember that we started thinking that this study would be in another AI community and
Correct.
in person.
Yes, that's a notable thing to mention. It started off originally in the Colville Reservation, and there's already a study ongoing with a participation list. But what happened was the tribal IRB said, you can do the study, but you need to wait 6 months. And of course, I'm class of 2022, so there wouldn't be a way feasibly for me to graduate this year and wait for Colville. So that was another issue. And then we started with another tribe, the Lummi tribe, an initially similar thing. The tribal IRB, due to COVID and other just complications along the way, so that we have to wait a little bit longer to do research on tribal land.
So a question from Steve who says, let me find it. I lost it.
It's about the AIN not being eligible.
Exactly, yeah.
So like I said, our study is about urban Indigenous folks or AIN populations. Because they live in a metropolitan area, 60% of them lose the federal access to having the Indian Health Services free insurance. So they aren't eligible to get the services that they should have the blood right or the federal recognition to. And then they also might have issues accessing the public or other forms of insurance. And that statistic is from the American College of Obstetricians and Gynecologists. And they wrote a whole opinion article about health disparities and reproductive justice for American Indian women. So there's a large gap here and not a lot of research.
Mm-hmm. I'm going to take 2 more questions. So Christina says, admirable work, Bianca. Just wondering why do you think there is such literature scarcity on this topic?
So I will say one reason I think that there could be is on certain posts, they consider American Indian Alaska Natives as a population like statistically like negligible because they're so small, and they're often overlooked by their size for a larger population. So I think that's one thing. Working with tribal IRBs could be another issue. And I definitely believe some of the hesitancy is the history of exploitation on Native people and Native bodies, similar to BIPOC people. And then also, like Beth said, there's a lack of funding, and funding drives research. So if there's not a lot of funding in this issue, there's not going to be a lot of work done with this population.
Thank you. And Bernardo, can you please close us off with your question?
Yes, briefly. No, Bianca, I mean, I see you are doing big efforts to increase your response rate, but more concerning maybe if there can be a bias that some people tend to respond more than other groups. Any thoughts on that?
Any thoughts on that? As of right now, I don't have enough research to know if the community is less responsive. I do know from my talks and training with 7 Directions, usually most of the participants in American Indian work, they do it because they just want more research out on their community. So the people who tend to participate, it's because they're just truly passionate of, there being more work involved. But we also want this to truly go back and benefit their community in a way that they feel empowered. And that's why we're working closely with other Indigenous leaders, including my thesis chair, Myra, to try to make sure that we're being as equitable and as culturally competent as possible.
Perfect. Well, thank you so much, Bianca, for that amazing, amazing presentation. I'm so proud of you, and that was amazing. Good job.
All right, thank you. Thank you so much, everyone.
Very nice, Bianca, congratulations. And now we will move to the next presentation by Kathleen Maloney.
Hello, everyone. So my name is Kathleen, and I'll be presenting today about the thesis project that I've been conducting under the guidance of my committee, which is entitled After the Fire, a Qualitative Study of the Role of Long-Term Recovery Organizations in Addressing Rural Community Health Needs. So to begin, I'll share a bit about my own background and positionality in relation to this project. I'm originally from Spokane, Washington, and I identify as a cisgender white female. And while I currently work in academic research, I spent several years working at disaster relief and/or recovery organizations prior to joining the MPH program here at UW, first at Catholic Charities of Eastern Washington and later with the American Red Cross. My roles in this particular project included study design, development of the REDCap survey and interview guide, participant recruitment, and data collection and analysis. So as many of you are likely aware, wildfire activity in the US has increased in intensity and duration over the past several decades. And in 2020 alone, nearly 59,000 wildfires occurred in the US, cumulatively burning over 10.1 million acres. These wildfires have massive economic and social consequences that impact communities for years after the disaster, disrupting housing, employment, and other social determinants of health. Given that the cumulative burden of wildfire damage is expected to increase over the coming decades, it is of critical importance to understand what constitutes an effective community recovery process after a wildfire. A key component of wildfire recovery in many communities are what's known as long-term recovery organizations, or LTROs, which are also called long-term recovery groups, or LTRGs. LTROs are collaborative groups that form to serve the recovery needs of a community in the wake of a disaster. And what differentiates LTROs from other organizations that support disaster recovery is that they remain dedicated to the communities whose recovery they originally formed to support, often operating for years after the disaster. In rural communities where social service delivery infrastructure may be limited even pre-disaster, LTROs ideally provide a coordinated entry point for community members to access resources that address key social determinants of health. However, despite this key role that LTROs often play in community recovery, they've been the focus of very little research, which brings us to the motivation for this current project. LTROs can take on many different forms, but here's an example of the type of long-term recovery group structure that you might see if you were to attend a disaster recovery training put on by a national level organization. You have perhaps a board or an executive director overseeing various committees, each tasked with a particular aspect of the community's long-term recovery. And before I move farther in this presentation, I just want to define a few key terms, which will come up throughout. The first is FEMA, which stands for Federal Emergency Management Agency, which is a federal government agency that supports communities and their members in various disaster preparedness, response, and recovery functions. If a disaster receives a major disaster declaration, impacted communities can be declared eligible to receive public assistance and/or individual assistance from FEMA. Public assistance is for state, tribal, and local governments to support the repair or replacement of disaster damaged facilities or infrastructure. And individual assistance is for individuals and households, and it can include a range of services such as housing assistance, disaster case management, and mental health counseling. Disaster case managers or management, whether provided through FEMA or other organizations, are commonly referred to by the acronym DCM. And SBA loans are low interest loans provided to businesses and homeowners impacted by declared disasters. So the first and primary aim of this project was to identify barriers and facilitators to LTRO's ability to address community health needs throughout the recovery process. And in order to examine community health needs from a health equity perspective, we employed the Robert Wood Johnson Foundation's Health Equity Framework, which includes 4 domains: making health a shared value, cross-sector collaboration, creating healthier, more equitable communities, and strengthening the integration of health services and systems. We also had 2 secondary aims, which were to assess the degree to which barriers and facilitators to addressing community health needs occur at the organizational, community, and societal level, and also to describe if intra-community inequities in access to LTRO facilitated resources occur throughout the recovery process, and if so, how and why. Here's a brief overview of the study methods. Our inclusion criteria for the study was current or former LTRO leaders serving rural communities in Washington, Oregon, or California that have been impacted by a wildfire disaster between 2015 and 2020. Data collection involved a brief pre-interview REDCap survey and semi-structured interviews with each participant. And for data analysis, we employed thematic coding with the Robert Wood Johnson Foundation's Health Equity Framework guiding the development of a priori codes and additional codes added through an inductive approach. And now a quick overview of the results. Here's an overview of the 6 long-term recovery organizations that participated in our study. 2 were from Washington, 3 were from Oregon, and 1 was from California. 4 of the 6 wildfire disasters that the LTROs formed in response to occurred in 2020. And while all of the wildfire disasters eventually received a presidential major disaster declaration, only 4 were granted both individual and public FEMA assistance. While all LTROs had at least 1 employee at some point in their existence, half never had more than that 1 employee. And most of the participating LTROs' leadership was primarily comprised of community members. From those 6 LTROs, the study had 18 individual participants. Around a quarter of the participants were survivors of the wildfire themselves, and 4 of those 5 participants had actually lost their homes in the fire. Over half the participants were current board members, and just under 40% were current employees. Around 45% of the participants had served on the LTRO for between 1 and 2 years. And the majority of participants had no prior disaster relief or recovery experience prior to joining the LTRO. Now I'll review some of the key themes that emerged from the qualitative data. The first theme is that flexibility of policies and procedures created at the societal level are a facilitator of LTRO's community recovery work. Examples of this include relaxing land use and building regulations, FEMA representatives dressing in plain clothes to better engage with undocumented or mixed documentation status families, and activating SBA assistance prior to a major disaster declaration when this declaration was delayed. As one participant said, the county is really chilled on a lot of land use regulations because they realized it was more important to get people home than it was to have this idealized housing concept. Another key theme was that standard procedures governing access to important recovery resources exacerbate pre-existing inequities. Examples of this include that those with informal rental or housing arrangements are unable to be served by FEMA or standard DCM models. Multi-generational households receive less FEMA assistance because they reside under a single roof. And the FEMA denial and appeal process is time-consuming and difficult to navigate. However, LTROs can build flexibility into their structure to mitigate the impacts of these policies. This includes relaxing policies governing the DCM intake process to the degree possible, creating a dual case management process that allows those who don't qualify for standard DCMs to access recovery resources, and extending the length of time after the disaster that residents can enter the DCM process. As one participant said, the state DCM process was removing people that did not meet this strict definition of a resident. We hired someone whose job it is to talk to these people and get them before the unmet needs roundtable. A third theme is that the degree of collaboration across all sectors greatly impacts the services that individuals receive. For instance, lack of information sharing requires survivors to provide the same information over and over, re-traumatizing them. A failure to coordinate access to recovery resources causes survivors to miss out on those resources. And miscommunication or misinformation leads to a breakdown in trust between the community and the LTRO. One participant described being promised an information sharing agreement with FEMA that would provide them a list of impacted community members to follow up with, only to be denied that information over a year later. As they said, there's still the potential that we may never fully identify all of the survivors who had a direct impact from the fire. The fourth theme is that post-disaster economic health is a key community level barrier. For instance, those with insurance or other financial resources may leave the community entirely after a disaster. The wildfires caused a huge loss of affordable housing in the community, and businesses couldn't operate without that workforce that relied on that housing. And a loss of revenue for the community leaves a lack of funding to rebuild infrastructure or community spaces. One participant. One participant described the huge impact that the loss of affordable housing had on the economic health of their community, saying you have all these people, you have to have people to spend money to employ service employees in restaurants and service businesses, and you can't have service businesses if you don't have employees. So what are the key takeaways from all this? The first is that standard policies governing access to FEMA and the DCM process more broadly should be revised to facilitate greater community access. Secondly, the economic recovery of individuals in the community as a whole is a difficult but key piece of recovery that should be included in standard models of LTRO functions. And finally, LTRO models need to be flexible and adaptable to morph as recovery needs shift to facilitate better access to resources and collaboration. And with that, I just want to give a huge thank you to all the participants, my thesis committee, Nicole Arrett, Jamie Vickery, and Jeremy Hess, and to Christiana, who helped de-identify and review all of these interview transcripts for accuracy. And thank you so much, and I welcome any questions.
Thanks so much, Kathleen. Very nice, interesting work. We have comments, questions.
A lot of congratulations at the moment.
Thank you so much, everybody.
Kathleen, this is Jeremy. While the congratulations come in, I wanted to ask whether there were any systematic differences in the fires and the recovery packages for the different communities that you studied.
Do you mean in terms of like FEMA assistance or?
Yeah, so I mean, both, you know, in terms of the extent of the fire and the damage, but then also in terms of the FEMA recovery investments that were made.
Yeah, definitely. So one of the interesting things came up is 2 of the LTROs I spoke with had delayed presidential disaster declarations. And neither of those ultimately ended up receiving individual assistance. They received just the public assistance. And that, I mean, the delay had a huge impact on the community because like there's this huge like funding loss for the community as a whole, right? That happens when you have all the residents suddenly leave because all the housing is gone and they're not paying like, you know, municipal water bills or these sorts of things anymore. The community can't even like fund like, you know, picking up trash or like, you know, replacing any of the infrastructure. And if you don't have that like FEMA public assistance to fund those activities, they're really like, it just holds up the community recovery process in a huge way. With not having the individual assistance, like despite all sort of the hiccups and kind of inequities with the way that assistance is delivered, it is still a source of temporary housing and support for a lot of folks. So that definitely impacts the recovery as well. In terms of the scale and the impact of the disasters themselves, like all of the wildfires included in this study were like quite destructive and destroyed significant portions of the communities, if not basically the entire community. So while like the number of people displaced was different because the size of the communities were different, I would say in terms of like the impact, like, you know, percentage wise of the community, they were comparable in that sense, I suppose. Yeah.
Great, thank you.
Thank you for that response. You have a question from Nicole, who says, what was the reaction/reception of the LTROs you interacted with regarding the work you were doing?
They were, a lot of them were, I guess, like very excited to participate. And a lot of them like took a little bit while to respond, because one of the things that came up a lot is like, a lot of these folks are like volunteers serving in leadership positions on these organizations, basically as like a second full-time job. So they're busy people. But once they kind of, you know, once we were in touch and they learned more about the purpose of the study, they were excited because I think they just like honestly haven't been the focus of very much research. There's been a small amount, and I mean like very small amount of research on long-term recovery organizations that is focused primarily on like post-hurricane impacts, and is focused much more, you know, on the East Coast and like tends to focus more on urban communities. So I think they were just excited to sort of feel included in the research process on recovery. And a lot of them are actually involved in kind of advocacy work on kind of how to improve the recovery process as well.
Perfect. Thank you so much. So we're at time, but you do have a question from Jamie. If you can just respond to that, that would be great. A lot of congratulations were also sent your way, so please make sure to read through those as well.
Yeah, will do. Thanks so much.
All right. Thank you, Kathleen.
Thanks so much, Kathleen. We would move now to the next presentation by Leah Wood.
Okay, hi everyone. Can you see my screen okay?
Yes, we can.
Okay, brilliant. So hi, good afternoon. Thanks for that presentation, Kathleen. That was awesome and totally set me up really well this presentation. So I'm going to say thank you for that. My name is Leah Wood, and I am presenting on my thesis project characterizing the role of trusted sources for smoke risk communication in tribal and non-tribal rural communities in the Okanagan River Airshed Emphasis Area. We are totally workshopping this title, so please send your recommendations in the chat. And I'm happy to be joined here by my thesis committee, Drs. June Spector, Nicole Arrett, Ann Bostrom, and Savannah Devlin. So first, on the left are relevant identities that shape how I approach this project and how I am perceived by others. And on the right are responsibilities that I held as a member of the project team. Throughout this presentation, I'll share a little bit about how we accounted for some potential biases and blind spots. I also wanted to start with three figures to set the context of my presentation. The first, 745,000. This is the number of acres burned on the Caldwell Reservation in the past 20 years. And of those, 681,000 have burned in the past 5 years, and 145,000 acres burned in 2021 alone. And this included the Chewea Creek fire, which prompted the evacuation of the town of Nisfalem. And for reference, the Caldwell Reservation is about 1.4 million acres. The second figure is the proportion of days in OMAC with moderate air quality or worse in 2021. And this is the only government-run air monitor in the region. Acute exposure to fine particulate and smoke and other sources of air pollution is associated with exacerbated respiratory and cardiovascular conditions, as well as an increase in all-cause mortality. And lastly, this is the anticipated growth in wildfire activity in the region due to the impacts of climate change over the next several decades. So in response to the growing public health crisis of wildfire smoke, practitioners are placing an increasing emphasis on what we call smoke-ready communities. And this is where communities are aware of and prepared to manage the health risks of wildfire smoke. A key element of smoke readiness is locally and culturally relevant smoke risk communication delivered through a trusted source or intermediary. And so while my thesis is part of a larger study in collaboration with the Okanagan River Airshed Partnership, as well as the Confederated Tribes of the Caldwell Reservation, I'll be focusing on aims looking at who is trusted and why within this context. And so our study focuses on the area, which includes the Okanagan River Valley and the Western Caldwell Reservation in north central Washington. This region is rural, lower income than the Washington average. Communities tend to be a mixture of tribal members and non-tribal community members. There's a significant agricultural and forestry presence in the area, which is managed in part by the Confederated Tribes of the Caldwell Reservation. This is a confederation of 12 bands whose traditional territories stretch across central Washington and who have used fire as part of their land management strategy since pre-colonial times. And they continue to act as leaders in the tribal burning rights advocacy movement in the state. This study used qualitative data collected through a series of key informant interviews and focus group discussions, which were transcribed, coded, and analyzed using a thematic analysis methodology. This project was approved by both the UW IRB and the Confederated Tribes of the Caldwell Reservation's Tribal Council. Our community partners identified tribal and non-tribal public service staff and leaders in 7 stakeholder categories as shown here. Interviews took place between June and November of 2021 over both Zoom and phone because of COVID. We're wanting to respect that. And then focus groups were held in person in both OMAC and Nisfalem in October and November of 2021. And they were grouped by age into youth and young adults, mixed ages, and elders. And we recruited people aged 16 to 25 for the youth groups and age 65 plus for the elder groups. For my analysis, I used a thematic analysis approach to identifying themes, which started with the development of a code book using inductive codes from the data, as well as deductive codes adapted from the health belief model and theory of planned behavior. Myself and a co-investigator co-coded 4 of the 23 transcripts and revised the code book in several iterations until we were coding in a similar manner consistently. Coded segments were plotted onto a matrix using the framework method to facilitate theme identification. And to ensure the quality of the project's design, implementation, and analysis, we used member checking as well as an iterative feedback process with our local partners to the process. And so this is an overview of the findings of the study, which are encapsulated in 3 main themes. And within each theme are several sub-themes which lend additional nuance to the discussion. I'll go into each of these in more detail, but wanted to note that the T's and NTs represent sub-themes that were most strongly communicated in tribal versus non-tribal data, respectively. So across all interviews and focus groups, participants described a preference for local sources of information. So these include local groups, agencies, and individuals. State and national level agencies or media sources were generally less trusted, resulting in part from perceived distance from local concerns, differences in political ideology, a lack of accountability, and negative past experiences with these agencies. Tribal participants expressed a clear preference for information delivered through the tribe, and specifically referenced seeking information from the staff at the Environmental Trust Department and Mount Holman Fire Center. Non-tribal participants were less uniform in their responses, but described local agencies and nonprofits as generally well trusted. Both tribal and non-tribal participants described strong informal networks of neighbors, friends, and family, and would often say that these were communities where folks really watched out for each other. They also described, thank you, a preference for information shared over social media and kind of the strength of these local fire watch Facebook groups where community members share hyperlocal information about fires as they happen. So this quote illustrates one of these points, which is, where I look is our tribal broadcast that our information person puts out. That's where I look. And I chose that source of information because I feel it's, it's up to speed, it's handy, it's reliable and accurate. In describing why some sources were more trusted than others, responses fell into 3 main categories: credibility, quality of information with and relationships with the source. As an example, local and tribal fire departments were viewed by both tribal and non-tribal participants as highly trustworthy because of their direct expertise on fires, their perceived political neutrality and lack of an agenda, and being firmly rooted within communities. Within these characteristics, tribal participants identified authority and expertise of the source, accuracy, timeliness of the information, local and tribal relevance, and relationships as important to evaluating trustworthiness. Non-tribal participants identified perceived political neutrality, transparency, authority, and respect as most important. And one quote that illustrated kind of the strength of relationships and the importance, and some of the factors leading into that is tribal members are more trusting than they used to be, because now we have a place at the table where we can voice our opinions. And there was a time when that didn't happen. But now we've been asked to participate in a lot of important events that are going on, and so the relationships have grown quite steadily. And this is in reference to the EPA as well as state agencies. Over half of non-tribal interviewees described Okanagan County as a majority conservative area or red county, and reported that non-conservative government or media entities were perceived to be less trusted, especially at the state and federal levels. For the sake of time, I'm not going to read the next few quotes out loud. Several participants highlighted the perceived parallels with polarization around COVID-19, noting that while public health agencies are authorities on the health impacts of smoke, they may be viewed as having a political agenda and lacking in transparency because of their linkages with COVID-19 and vaccines. Many tribal and non-tribal participants shared the perception that community members in the area were more likely to trust information shared by friends and family and people in the community with whom they had relationships and shared values. Participants emphasized the importance of strong relationships and communication, described the opportunity to leverage relationships and well-respected community members as spokespeople in bridging ideological differences around topics related to smoke and health. And so this project confirmed and extended findings in the existing risk communication literature by answering not only who is trusted, but why, within the context of environmental hazard risk communication in rural and tribal communities. And this project also confirmed that state and federal agencies may be less trusted for a number of reasons, including historic marginalization and disinvestment, failing to respect treaty obligations, and distance from the experiences of rural and tribal community members. With that being said, I offer the following implications for outside of the community practitioners, like myself, I'm a state worker, especially those from government agencies. In particular, these findings highlighted the need for intentional collaboration with local and tribal partners to deliver information, engaging partners throughout the design and implementation of the project, as well as working to build local capacity. And this collaboration was center relationships, emphasizing government accountability and authentic engagement with communities around environmental hazards. And lastly, for state and federal agencies working with tribal nations, this includes following formal government-to-government consultation processes in addition to project-level collaboration. This study was an in-depth qualitative study, and many of the potential limitations of this project can also be counted as its strengths. We were able to conduct rich, in-depth inquiry into this specific topic and work in collaboration with our local partners who brought invaluable expertise. The study was conducted entirely in English, however, and an area for future study should include Spanish language engagement and targeted outreach to agricultural workers in the area. So I'd like to conclude just by thanking my project team and thesis committee, many of whom are here today, as well as my friends, family, community mentors, and colleagues, and especially my partner, Ben, who has been both my sounding board and copy editor over the past year and a half I've been working on this project. And then lastly, a huge thank you to our participants for sharing their time and perspective. Thank you. Any questions?
Congratulations, Leah, great work. Comments, questions?
So there's a comment from Steve who says, really great study and presentation, Leah. The lack of, it's happening so fast. The lack of trust of government agencies depending on political parties concerning, though not unexpected these days.
Yeah, it was it was my hypothesis going into this study that we would find this, though it was actually fairly hard within the academic literature to defend that. It's something that I feel like if you spend any time in a rural community or just talking to people generally, we know that the polarization is getting stronger and that there's a lot of mistrust around it.
Yeah. You have a question from Nicole who says, same question as I asked Kathleen. What was the reaction/reception of the community members and leaders you interacted with regarding the work you were doing?
Really great question. And I would say overall, folks were really interested in sharing their experiences. Something that I didn't mention earlier is that, so last year was a huge wildfire season and they were happening while we were doing data collection. And so I think a lot of folks wanted to share about what was happening in their communities. And we asked a lot of questions around topics, not just around trust, but around wildfire smoke impacts and risk communication generally. And so folks were generally really happy to share. They were willing to connect us with other people. And I think also in part of that is just the community partners that we worked with who helped facilitate introductions.
Great, thank you. And there's a question from Cody. So Cody, please go ahead.
Not a question, just a comment, and thank you to Leah and Savannah. I'm the Natural Resource Director and Interim Executive Director here for the Qual tribe, and would say that this work went a long ways in helping inform the decisions we make as a tribal government to help mitigate and protect our tribal members from smoke impacts, because as you said, we've burned almost half the reservation in the last 6 years alone. So this is a persisting issue. It's likely going to get worse before it gets better. So her work will be invaluable in protecting, especially those sensitive populations in the future. So thank you and great presentation.
Thanks, Cody.
Any other questions or comments for Leah? A lot of congratulations, so it's very well deserved.
Thanks, everybody.
All right, well, with that, Leah, thank you so much for your time and your presentation. Thank you.
Sure.
Thanks, Leah. We would move to the next one. It's by Azalia Thompson from the Health Metrics and Evaluation track. Azalia, please.
Thanks, Bernardo. Let me share my screen. All right. Well, thank you everyone for being here. I'm excited to tell you about my thesis today on examining the effect of hydroxyurea treatment on healthcare spending and utilization among patients with sickle cell disease. So following on from Leah's presentation, I just wanted to start with the land acknowledgement. So we are on the traditional land of the first people of Seattle, the Duwamish, and I just wanted to honor that in the land itself, in the Duwamish tribe. And also just to note my positionality. So sickle cell disease is a life-threatening disease that disproportionately affects marginalized identities and has disparate health outcomes rooted in systemic racism. So as a white woman not affected by sickle cell disease, who does not suffer from acute or chronic pain, and is not a physician who treats patients with this disease, I will never fully understand the experience of those living with the disease. And I also just wanted to give a bit of background that I model global estimates of sickle cell disease for the Global Burden of Disease study. So for some background on the disease itself, sickle cell is a genetic blood disorder that arose historically in Africa due to its protection against malaria. And as a result, it is most common among those of African, Middle Eastern, and South Asian descent, with about 1 in 360 African Americans and 1 in 16,000 Hispanic Americans born with sickle cell disease. Those with sickle cell have a genetic mutation that changes the hemoglobin protein and causes the body to produce a sickle or crescent-shaped cell that can't flow easily through the veins and therefore has trouble carrying oxygen throughout the body and increases health issue risks like infections and stroke, and also shortens life expectancy. So the most common experience of a person with sickle cell disease is that of acute pain crises. Depending on their genotype, on average, someone will experience between 3 and 4 pain crises a year. However, there's an inexpensive drug called hydroxyurea that effectively reduces pain crises. And it essentially works by changing the type of hemoglobin that the body produces. And so it increases the production of fetal hemoglobin, which actually doesn't produce sickled cells, even in people with the disease. However, we know that even in high resource settings, hydroxyurea is underutilized for reasons such as provider lack of knowledge, patient or family misperceptions of risks, limited support from lay organizations, and inconsistent medical delivery systems. So unfortunately, there's a lack of data on hydroxyurea usage in regions like West Africa, where the burden of sickle cell is highest. So due to wider data availability in the US, I was able to use the MarketScan, commercial claims and encounters databases to examine outcomes on healthcare utilization, spending, prescriptions, and diagnoses. And these databases contain information on patients who are insured by their employers and their dependents between the ages of 0 and 65, and I selected a group of patients for the most recent years available between 2016 and 2019, patients who had a diagnosis of sickle cell disease as coded by ICD-10 diagnosis codes, and who were in the data set for at least 365 days. So with this scope, I developed 2 aims. Firstly, how do healthcare utilization, spending, and pain crises vary among individuals with sickle cell in the US before and after prescription of hydroxyurea? And second, if individuals with sickle cell disease not prescribed hydroxyurea were placed on the treatment regimen, what would be the effect on pain outcomes, healthcare utilization, and spending? So for a brief overview of the selected group of patients represented in the claims database, here you see the distribution of patients in the control group, or those who never received a prescription of hydroxyurea, in blue, with those in the treatment group who received a hydroxyurea prescription at some point in red. And you can see that most treated patients fall in the 10 to 19 and 20 to 29 year age groups, while those not treated comprise a greater proportion of the youngest and oldest age groups. Next, you see that both males and females are in the treated group approximately 30% of the time, with similar proportions across regions. And finally, among the 4 sickle cell disease genotypes, the treated group is disproportionately the homozygous genotype, and the control groups comprise the other genotypes by at least 75%. Oh, and then one more, across years, 2016 has a lower proportion of treated patients than the other years, in which again, about 30% of the patients are treated. So after extracting the relevant patient group and coding patient genotypes based on ICD diagnoses, I conducted two main analyses. First, I established a group of sickle cell patients who received a hydroxyurea prescription at any point. I then determined a subgroup of 631 patients who were present in the dataset at least 90 days prior to receiving their initial prescription of hydroxyurea and 360 days post. I then carried out two-tailed t-tests to compare the mean outcomes in care utilization, spending, and pain crises per 90 days. And I then ran negative binomial regressions to estimate these mean outcomes over 5 90-day time periods.
5 minutes.
Thank you. Next, I compared sickle cell disease patients who had never received a prescription for hydroxyurea to the previously established treated group, and I used propensity score matching to match these cohorts on age, sex, and genotype. I repeated the t-tests and regressions to compare mean outcomes between control and treated groups, and then applied the ratios determined in part 1 for the change in outcome pre and post hydroxyurea prescription to estimate the potential averted care utilization, pain, and spending if the control had received the treatment. So for an overview of the matched cohort demographics, you can see that the control and treated group had nearly identical composition across age group, genotype, region, and sex. The late teen and early adult age groups comprised about 50% of each cohort, with over 80% of the patients with the homozygous sickle cell genotype, an overwhelming majority of patients in the South, and slightly more females than males in the sample. So getting into the results, this figure shows the number of pain crises incurred per 90 days among treated sickle cell patients pre and post treatment, as well as control patients in gray over the same time period. So overall, you can see that treated patients have higher crises, about 1 per 90-day period, compared to non-treated patients who have about 0.4 crises per 90 days. However, you also see that in the treated cohort, pre-treatment pain crises are higher than post-treatment, and you can see that inpatient and outpatient pain crises follow a similar pattern as total crises. So comparing pre and post crises per 90 days, these decreased by about 22% overall, 38% in inpatient, and 13% in outpatient. Looking at healthcare utilization among the same patients, you see a similar pattern to pain crises. So among treated patients, they have about 5 visits per 90-day period compared to non-treated patients who have about 2 visits. And then post-treatment, you see a decrease in total care visits of about 12%, in emergency visits of about 29%, 35% in inpatient, and 2.6% in outpatient. Finally, looking at health spending, treated patients spend about $10,000 per 90 days compared to around $4,000 in non-treated patients. And once again, you see that's higher in the treated cohort before treatment, and then after treatment, there was a decrease overall in spending of about 33%. So in conclusion, we see that sickle cell disease patients have significant reductions in inpatient and emergency pain crises, care visits, and spending after being treated with hydroxyurea. And in a counterfactual scenario, if the control patients were to receive hydroxyurea, per patient, total visits would decline by about 1 per 6 months, by about $3,000 per 90 days, and by about 1 pain crisis per 1.2 years. It is unclear why sickle cell patients on hydroxyurea have higher overall utilization and spending, but we hypothesize that it's potentially due to higher disease severity, which we incompletely controlled for in matching these cohorts by genotype. Future directions that I hope to take in this thesis are to examine patterns in the treatment group for hydroxyurea initiation, and then use the number of days prescribed hydroxyurea as a continuous predictor rather than a binary. And then finally, I hope to examine the effect of hydroxyurea on other sequelae of sickle cell disease, for example, stroke. So finally, just acknowledging my thesis chair, Dr. Nick Kassabaum, committee member, Dr. Joe Dealman, Dr. Amy Hagopian, Jimmy Dexon, and CH teams, my UW community, friends, and family for your guidance and support. Thank you.
Thanks so much, Azalia. Very interesting results. and very detailed analysis. Comments, questions?
Yeah, Bernardo, start us off, please.
I can start with one right away. I mean, when doing your propensity score matching, Azalia, how big is the proportion of cases that you could not match because either that your score was too low or too high, that they were not in this area of common support?
Yeah, so I was able to, I initially had to subset the patient group to those who had at least 60 or 90 days prior to receiving that prescription, and then at least 360 days post-prescription. So that was more of a limiting factor actually than the having enough controls to match on. I was actually able to do that without losing out any of the treated patients.
Great. Any other questions for Azalea? Comments, suggestions? Wow, you are also very thorough that everyone understood everything then. Anything else? Okay, well, if anything comes to mind, please make sure to add it in the chat box. And if I see it, Azalea, I'll try to flag you so you can respond to it in public. But thank you so much for your time and for your presentation. Thank you.
Thanks.
Thanks so much, Azalia. And well, with this, we would move to the final presentation of the whole session. It's by Ryan Fitzgerald, also from the Health Metrics and Evaluation track. Please, Ryan.
Okay, are we good to go?
Yep, go ahead.
Okay, cool. Hi, everyone. My name is Ryan Fitzgerald. My thesis is called Quantifying the Effect of Upstream Maternal Risk Factors on Racial and Ethnic Disparities in Neonatal Health across the United States from 2000 to 2019. Also, as a heads up, I'm really not feeling well today, but I'm gonna do the best I can. Before I start, I also want to say, you know, as a white man, racism in healthcare and also pregnancy are two things that I'll never experience. And that said, I think this is really important work, but throughout this, it's also been really important to consider kind of where I stand in relation to the work. So I do just want to start off by saying that. And I also want to thank my committee, Nick Kassenbaum and Bobby Reiner, who are on the call today, for helping kind of guide this along. So a little background about racial disparities, specifically in neonatal health. Historically, up until about 1997, it was thought that racial disparities in neonatal health were primarily due to genetics, that there was something genetically different about people of certain racial or ethnic groups that predisposed them to having worse neonatal health outcomes, specifically non-Hispanic Black women and non-Hispanic Black infants. There was a landmark study done in 1997 that compared the birth weights of African immigrant born women's infants with the birth weights of infants born to US born white women and US born Black women. And that study found that the birth weights of African immigrant women's babies were more similar to US born white women than US born Black women. And that really just totally disrupted this notion that everything was rooted in genetics. And it really highlighted that there is something unique about the structural factors that impact Black women in America that contribute towards worse neonatal health outcomes, and that genetics is not the primary driver. So since then, in recent decades, research on social determinants of health has really grown, and many of risk factors disproportionately affect racial and ethnic minorities due to long, complicated histories of structural racism. Also in recent years, the role of maternal risk factors and impacting neonatal health has been increasingly recognized as very important. It's no longer just about what happens to the infant in the first month of life. It's increasingly been realized that it's important about what happens to the mother during her 9 months of pregnancy and even before that. Those maternal risk factors are often broadly categorized as environmental risk factors, behavioral risk factors, and clinical risk factors. And exposures to those risk factors often vary pretty dramatically by race and ethnicity. So the specific aims of the study that I've done is to calculate the attributable burden or the attributable neonatal health burden of low birth weight and short gestational age by state and race ethnicity. And then I have also aimed to assess the extent to which 3 risk factors, 1 environmental, 1 behavioral, and 1 clinical, explain that state, race, ethnicity specific neonatal health burden. The data that I've used to do this is first the US National Vital Statistics System data from 2000 to 2019. That includes over 80 million births. It's essentially a near census, missing only an extremely small percentage of births in a few states in a few years. And then I've also incorporated 3 analyses that estimate how much we would expect a birth weight and gestational age to have been higher without the presence of maternal risk factor exposures. So for my 3 risk factors of air pollution, which is my environmental risk factor, maternal smoking during pregnancy, which is my behavioral risk factor, and gestational hypertension, which is my clinical risk factor. Without those exposures, how much higher would we have expected birth weight and gestational age to be? And I do that using individual level data from NVSS on cigarette smoking and gestational hypertension, and county and race ethnicity specific estimates of air pollution exposure. Some like high-level data processing steps that we took. We only included singleton live births, which means no twins or triplets, from births that included the race ethnicity information for mothers, as well as birth weight and gestational age. Birth weight values were unadjusted because the reporting measure was consistent throughout, whereas gestational age values were standardized because there was 2 ways that gestational age was reported, one being based off a woman's last menstrual period, and the other being based off an obstetrician's estimate. The last menstrual period approach tended to underestimate gestational age in preterm births and overestimate gestational age in post-term births. So that's what this plot is showing, the adjustment factors for how we adjusted gestational ages reported with last menstrual period. And then we also mapped any race or ethnicities to the US Office of Management and Budget 1997 standards for race and ethnicity, which are kind of a somewhat of a norm in the field that has 5 categories. So we've done this for every state, race, and ethnicity, and I've decided to walk through one example, which is non-Hispanic Black women in Wisconsin. That's where I'm currently living right now, so I've chosen that. So you can see in this plot, there are in each of these 4 distributions of birth weight and gestational age, where the pink distribution is the observed distribution, and then there are 3 counterfactual distributions in each case where the distribution is shifted slightly to the right. That is, each of those is a distribution where the effect of that risk factor has essentially been removed for mothers who experienced that exposure. So distribution shifts slightly to the right overall. And as those distributions shift to the right, the possibility of some of those births being shifted into a lower relative risk birth weight and gestational age category arises. So it's possible that a mother or that an infant that was 20 times more likely to die during the neonatal period got shifted into a bin where they were only 12 times more likely to die. And that relative risk results in a lower population attributable fraction. So This plot on the right shows the observed and counterfactual population attributable fractions, with the path for maternal smoking often being significantly lower, gestational hypertension frequently being significantly lower than the observed, and air pollution pretty much being insignificantly lower than the observed in almost all state, race, ethnicities. And so we repeated that process for every state, race, ethnicity. So this first result kind of just highlights the exposures that every race, ethnicity experienced for the 3 risk factors. The top left showing air pollution, where American Indian, Alaskan Native mothers experience the lowest air pollution, and other race ethnicities being fairly similar, with non-Hispanic Black exposure to air pollution being slightly higher than the rest. Gestational hypertension was most common amongst non-Hispanic Black and non-Hispanic American Indian, Alaskan Native mothers. And smoking was by far most common in American Indian, Alaskan Natives and non-Hispanic white women. So this plot shows for every state, but it's probably easiest to just focus on the one at the bottom right for Wisconsin in that example, and then we'll look at kind of the other states in general. This is showing the low birth weight rate by race ethnicity state in 2019. So there are 5 groups of bars for every state, and there are 4 bars in each group. So you can see in general that the low birth weight rate is highest for non-Hispanic Black women, and even the counterfactuals do not erase the racial disparities, although they do mitigate them to some extent. And so you can kind of see for each race ethnicity how much those counterfactuals would contribute towards mitigating racial disparities. And that's replicated for every race ethnicity state in the overall figure. The next slide does the exact same thing for preterm birth, which is births before 37 weeks. And again, preterm birth is generally most common in non-Hispanic Black women, and the counterfactuals mitigate racial disparities while not erasing them completely. And this trend is, again, mirrored for most race ethnicity states. This next slide shows population attributable fractions over time for race ethnicity states. So starting with Wisconsin, again, in the bottom right, the red line is generally highest in all states over time, indicating that the population attributable fractions for non-Hispanic Black women are highest. And the blue line for non-Hispanic white women is generally lowest. Other race ethnicities are often fairly close to the non-Hispanic white line, although slightly higher, and that's fairly consistent across states. The final 3 slides of results show how much we would expect that population attributable fraction to have changed or been lower over time with the removal of a certain risk factor. So the first one is air pollution. And here we expect pretty small reductions in the population attributable fraction. If you look at the y-axis, we're only looking at about 0.2% reduction in PAF. So air pollution is not necessarily mediating or explaining much of the population attributable fraction for low birth weight and short gestational age. This analogous slide is showing the same thing for maternal smoking. And here, because smoking rates, as I mentioned earlier, are higher in non-Hispanic American Indian, Alaskan Native mothers and non-Hispanic white mothers, generally the yellow and blue lines are higher than the lines of other race ethnicities, indicating that more of the path can be explained by maternal smoking, often in the range of about 2, maybe even 3%. And the final result slide does the same thing for gestational hypertension, where most race ethnicities are fairly comparable in terms of the percent reduction, and often it's in the range of 1 to 2% reduction in the PAF. So some high-level takeaways: racial disparities in neonatal health exist, and they are pretty severe. upstream maternal risk factors do contribute to these disparities, but no one maternal risk factor explains a sizable or large portion of that disparity. And in reality, it's likely a web of interconnected factors, including even more direct forms of racism, and specifically medical racism, likely explain a larger proportion of the disparity than the three fairly representative risk factors that I chose today. But there's obviously a lot more than just the three I've chosen for this. So some thanks. I just want to thank my committee, Nick and Bobby, for kind of guiding me along the process and helping me get started. And also the NCH team for kind of looking at some of these plots as I've plotted along. And also to the US counties team at IHME for helping answer some questions about race, ethnicity specific work and kind of some norms in the field. They've been really helpful. So that's all I have today.
Congratulations, Ryan, and thanks. You look in a pretty difficult situation, and even with that, we appreciate you come to make the presentation. It's a great work. We have time for some comments, questions.
Any questions for Ryan? All right, Bernardo, let's start us off.
I would have one question and one general comment and exploring your future steps, Ryan. But the first one is there a way you could analyze like a lower weight, considering the one that is associated with low gestational age and the one that is not associated with gestational age? And the other one is, I mean, it's striking that even in the different scenarios and controlling for these risk factors, the race ethnicity gap continues. So what happens? Is it possible to identify like some factors that may affect differentially some racial or ethnical groups?
Sure. I think, yes, we could do this analysis. To your first point, we could do it just with low birth weight or just with gestational age. We could also, using the data that exists, we could look at specifically size for gestational age. I think that kind of one thing that I took away from this is no matter how we quantify birth weight and gestational age, though, there are so many things that can't be accounted for biologically. Just kind of looking at the relative risks that we use. There are so many factors outside of the biology that contribute towards those relative risks that aren't fully captured here. And there's a study that I cite in my actual thesis itself that looks at racial concordance of mothers and doctors and the survivorship of Black infants and how much higher it is when Black doctors deliver those babies. And there's so many things like that that just can never be captured in an analysis like this. And so it's, at some point, an analysis like this can capture, biological factors, but it can't capture the interpersonal, more complex social dynamics of things like that.
Great, and you have a comment from Steve who says, very creative analysis, Ryan, plus you presented complex stuff in an understandable way. It really underscores the importance of SDH. Kudos. Any other questions for Ryan? That was very thorough. Anything else, comments? Okay. All right. Well, Bernardo, I think I'm going to throw it back at you to wrap us up.
Exactly.
If you don't mind.
No, really, thanks everybody, all the presenters. Really, it has been a very interesting session. We have really enjoyed looking all the work you have done. Thanks to not only your thesis committees, but also everybody that was involved in the work. Now we understand that there is one person presenting that maybe did a lot of the heavy lifting, but there's a big team in each one of the works behind, and we're so happy to see this. On the MPH program side, but also, of course, big thanks to the group of Steve, Deepa, who have been also helping with the students, but also Julie, Sarah, and especially Nura, that not only have been accompanying all the group, but also setting all of the logistics for this session. So we really look forward back to see you all guys do the final push. After these presentations, finish your thesis, submit it, graduate, celebrate, and why not think on a publication derived from this to really potential the impact of your work. No? I don't know, Steve, Deepa, you would have anything to add?
Well, Deepa had to step away due to a meeting, but I want to thank you, Bernardo and Sarah, Julie, Steve, all the advisors, the faculty and staff, and definitely the students for your hard work for the past 2+ years. You know, if it took longer to work on everything, thank you, Bernardo, for spearheading today. Steve and Julie, did you want to make a note before everyone left?
Just for me, not only thanks to you, Nura, to Julie, Deepa, but also to the students for really enlightening us with their amazing work and insights.
Yeah, same. The presentations were excellent, just really excellent. Such a pleasure to hear what everybody's been working on the last couple of years and to see the incredible impact that's been had all over the world. So great. And I hope you're feeling better soon, Ryan.
Great. Well, with that, I want to thank you all. Wish you a great day. I will have the links for both days by Friday at the latest. So you'll be able to review it, send it to friends, family, whoever you wanted. So thank you all. And with that, have a great afternoon or evening, wherever you're at. Thank you.
Thanks, everybody. Good afternoon.
Thanks, Bernardo. Thanks, Nora.
Bye.